Borador, good morning, everybody. Welcome. If we can take our seats, that would be really good. Just waiting for the refreshment counter to reduce its queue. Okay, if I just start off then with some basics, which are fire exits. They're well signed here and various places with a gathering point over at the car park. So there are no practices. So if there is an alarm, it is for real, and you'll see me out of that door before anybody else. So just be aware that there isn't a practice. Toilets are behind us here, and as I say, use them at will, because there's not that many gaps in the program. So please make sure that you are comfortable. Can we make sure that your phones are on silent? Traditional to do that. There'll always be one, I'm sure, but please make sure that they're on silent. Anna's checking that she's not going to be the one. There will be pictures taken today during the event. If anybody's got any reasons or any issues with that, can you talk to one of the guys over at the reception area so that we can make sure that that is noted and we work around it. The conference is online, so we're live online, and we are also recording as well. So just be aware of that for everybody, and that will then be available on the website going forward. If we could make sure online that cameras and microphones are off. It can be slightly difficult if people's microphones are on and we broadcast conversations that are happening at home, potentially, that we don't want to be broadcasting. So just make sure that that is the case unless you're asking a question or speaking. There will be opportunities for Q&A and chat, and the team will monitor those at the end of presentation so that the online questions, where possible, are put forward and answered. So please feel free to use that as and when. If you're asking a question, can you introduce yourself, please, in the room, just so people know who's who and who's asking those questions? That would be really useful. We have a poster display on there with a scoring sheet, which is available from the reception if you haven't got one in your pack. Please have a good look at those, and there's some fantastic work ongoing there. It'd be really good to be able to get the scores in for that. The top 3 posters will get awards. So just to be really clear, that that is available, and I will keep reminding you of that during the day. Translation is available if we need it. Well, I don't think we've got any notification of forward planning today on the Welsh language at the moment, but if there is a requirement to do that, we will have simultaneous translation available to us should that be required. Well, yesterday, what a day we had yesterday, where we were learning huge amounts about what's happening internationally and with colleagues in other countries. Finishing off with a stark message around social care and the demand for social care and what's happening out there if we don't do something differently. And I think it is really vital, that's why we're here, isn't it, that we do something differently. We heard yesterday about partnerships and not working in silos. We learnt around community and social care focus rather than the big shiny hospital focuses, and we did, as I said earlier, learn about growth in demand and what the likely end point of that is if we don't do something differently and we don't get the message that there is a need to work on the prevention agenda and on the community and social care agenda going forward. We've had a night of it. as well, which I'm sure people are picking up this morning with regard to what's happening across the world. So there's a little bit of a interesting scenario for us. And also, we've heard on the news today that a vital part of our provision in terms of healthcare and care in the community is not happy with where things are with regard to the contract offer that's been made to our general practitioner colleagues. So there's a real boiling pot out there of things that we need to make sure we get sorted fairly swiftly if we're going to be able to see this transition from a hospital medical based care system to a social model for health and community based system going forward. We can't ignore it. The tidal wave is coming and we've got to do something differently going forward. And those different things are coming out of conferences and meetings like this, coming out of work that's being done across the world that we can learn from and we can latch into and harness in our provision going forward. So what will tomorrow bring? That's the next question, isn't it? It's a 3-day conference this time. So, you know, I've got to survive another day. So tomorrow may well be a different story again of what's hit the headlines, particularly that may well affect the way that we look after our communities and the way that we look after each other in our environment, and particularly in the Mid Wales environment. So I'm going to, if that's okay, move on to, and I think Sarah Ann is online and I'm getting the nod, so that's good. Slightly early, Sarah Ann, so I'm coming to you in one moment. In terms of strengthening rural health through education and leadership. So I'm going to go over now to Sarah Ann, and over to you.
Many thanks. I'm just sharing my slides, so hopefully they will come up for you in just a second. Okay, that looks okay from my side, so hopefully you can hear me okay and see the slides as well.
Yeah, all okay. Brilliant.
That's great. Thank you. Well, it's lovely to be able to join you this morning via the internet. Sorry not to be able to be at the conference itself. I did manage to sit in on some of the talks yesterday, and it certainly has been a really interesting conference so far, and I enjoy I look forward to enjoying more over the next day and a bit as well. So thanks very much for inviting me to give a plenary presentation. My own background is in rural health academia. I'm a social scientist and a health geographer. I've worked in academia for the last 15 years or so, but this year made a move into the National Centre for Remote and Rural Health and Care, which sits within NHS Education for Scotland. And the National Centre was started towards the end of 2023. We're funded by the Scottish Government Directorate of Primary Care. So in our first phase, our startup phase, we are very much focused on primary care and community-based services. So what I'd like to do is introduce you really to the National Centre, our objectives, and some of the areas that we're focusing on in these early stages. So I'll describe some of the structural pillars of our work and give you some examples as well. We do have a website that you can access as well, so we'll make sure that we share that as there's lots more information that you can have a look at online. So the National Centre, as I say, was established in October 2023, and this was in recognition of a long-standing gap really in dedicated support for rural healthcare. We're building very much on the rural health education team, which has always sat within NHS Education for Scotland, but we've, as you'll see, extended that to bring in other areas, including research and evaluation. So within this phase, our objectives are really to support excellence in design, delivery and evaluation of remote, rural and island health and care research, evaluation, recruitment, education and leadership and practice. So we're very much a collaborative centre and working with partners to try and draw on existing good work and enhance some of the programmes, etc., that are already underway, but act as that central national contact point and facilitator for advancing rural health research and practice.
Thank you. I think Sarah Ann's gone.
Oh, sorry.
You're back now, aren't you?
That was my internet connection. I apologise. So yeah, we know what some of the successful factors are for rural health systems around the world. So the rationale for our centre is very much on drawing on these and looking at how they can be adapted and applied to different contexts within Scotland. So remote and rural and island communities. We also know what some of the key challenges are, and we've been hearing about those over the course of this conference as well. Within Scotland, we have around 17% of the population living within rural areas, but it actually covers about 98% of our land mass. So we're talking about quite dispersed, low population density, and alongside that, health inequalities and some quite persistent workforce challenges, alongside a higher infrastructure and cost for the delivery of services within these areas. So our work within the centre is organised around 4 core pillars, and we feel that each of these address really critical aspects of rural healthcare. And together that these can foster resilience and sustainability within rural settings. So each of the areas or the pillars that we work on combines to help us meet our overall objectives. We have a research and evaluation stream, which is the one that I lead, and that focuses on advancing rural healthcare research within the primary care healthcare workforce, and also within academic collaborations and with projects that we lead ourselves as well. And what we're trying to do there is really ensure that we have a robust evidence base that can help inform rural healthcare policy and practice. Our second pillar around education and training is really about promoting undergraduate, postgraduate and continuing professional development for rural practitioners. And within that, there's a lot of focus on preparing folk to feel that they can meet the sometimes unique demands of rural healthcare in practice. In terms of recruitment and retention, this attempts to tackle some of those long-standing workforce challenges and supporting recruitment, retention and also recognition for rural healthcare professionals. We also have the fourth pillar around leadership and good practice, and that fosters leadership within the workforce and equipping people with the skills to navigate some of those challenges that we know exist within remote and rural healthcare. So we feel like we've got a programme theory for our centre, a programme logic that draws on those examples of international evidence and success factors. So each of these pillars really helps contribute to meeting that overarching goal. And by integrating, I guess, these pillars within our work, what we're trying to do is help to create a rural health system that's resilient, but also adaptable, as we see those evolving needs within rural populations over time. So each pillar has a distinct but interconnected role. So our research and evaluation is around strengthening that evidence base, the education and training around ensuring practitioners feel well prepared and equipped, leadership and good practice around the resilience and problem solving, and recruitment and retention around addressing those workforce gaps. So we have quite a detailed programme theory that I could share with folk as well, but ultimately we feel that these pillars, through the actions within the work streams, will ultimately help us support sustainability of rural healthcare across Scotland. So I was just going to introduce you to the pillars in a little bit more detail. So each of these has its own section within our TURAS website, so you'll be able to go in and have a look in more detail at the different programmes of work that are ongoing. Obviously our education and training is focusing on ensuring those practitioners are well prepared and equipped, and that's around skills, knowledge and resilience, and we're supporting continuous professional development. We're supporting pathways for career progression within rural healthcare, and they're really focusing on some of those unique demands that are faced by practitioners within these settings. So a couple of projects to highlight. Firstly is the Remote and Rural Advanced Practitioner Programme. So this provides training and support for healthcare professionals at a master's level, and it's a structured approach to learning and skill building, allowing them to deliver high quality care. So the centre was a central partner in this, in the development of a capability framework for rural advanced practitioners, and that has been taken on by University of the Highlands and Islands, and the National Centre is then funding people already based within rural practice to be able to undertake the course remotely, and come out with a qualification, and also we hope an enhanced sense of identity and preparedness as a rural practitioner. So that's in its second year of funding just now, and there's ongoing work there to evaluate alongside the students that are going through the programme, and we've also put online support in place for the rural practice supervisors as well, so we will be looking to evaluate and understand the impact from that side as well. Some of the benefits that we can see coming out of this type of approach around a rural curriculum are things like practitioner confidence. They're having an enhanced feeling of competence, but also of job satisfaction. So it's also linking into retention within rural areas. The National Centre also delivers a series of learning events, and this is an ongoing programme throughout the year, delivered online in terms of different sessions, different topics, looking at multidisciplinary knowledge, and bringing people together around presentations and discussion. So really, again, trying to build that cohort of rural practitioners that value that as their identity as well. So just to highlight the leadership and good practice pillar, we've talked about this, promoting resilience and problem solving within the workforce. It's designed really to try and support resilient leaders who can address the types of challenges we know are present within rural healthcare. We know that folk often operate quite independently within a rural context, and they can face resource constraints, for example. And the goal of having a leadership stream is really to equip people with tools and skills and also peer support that they need to drive a positive change and service improvement. There's a few different ways that we're looking at this. One is the provision of funding for remote and rural practitioners within primary care around development awards. So really helping people to undertake professional development activities that may be a more formal route through a qualification or a project that they undertake within their work environment. But really allowing them to feel that they can grow professionally and also contribute to their communities. And we're looking specifically at funding some leadership awards into the future as well, and trying to grow that next generation of leaders for rural healthcare. At the moment, we have some international, again, online events bringing people together to try and foster that international dialogue and exchange of good practice. So recruitment and retention is the third pillar that I'd like to highlight. So I think it's no surprise that this is really central to addressing some of Scotland's challenges around rural workforce. We are looking to develop and also to implement and test strategies that would support recruitment and retention, and also the recognition of healthcare professionals in rural areas. For example, within the National Centre, we have a team who are facilitating a credential for GPs working within remote and rural areas, and that's the first of its kind within the UK, I believe. We've also got individual projects such as Making It Work, which I've highlighted on the slide here. You can see the framework associated with the project on the right-hand side of the slide. And this is really about collaborating and collaboration with healthcare providers to identify and then implement practical solutions to recruitment challenges. The work itself emerged from quite a long-standing EU-funded collaboration, and what the stage we're at now is to try and work alongside NHS boards and stakeholders to implement this and test it within Scotland, as it's been implemented in other international contexts, but not within our Scottish context. So you can see that there are the 5 conditions of success in the middle. You then are working through planning, recruitment and retention elements of the framework. And we're doing that at the moment with a group based within Skye in Highland. And the additional role that the National Centre team are bringing to that is to construct a monitoring and evaluation framework. And we're designing that through a co-design method with the recruitment group itself, and that's to really try and help give people tools to use to do that monitoring and evaluation function, which is one of the 5 conditions for success in the middle there. So we hope that the tools that we develop with the group in Skye will be able to be adapted and provide guidance within other geographical contexts within Scotland to where we're hoping that groups will then implement Making It Work, and also an evaluation alongside that. One of the other things that is supporting this work is our Living Library, which again will be a digital resource that is shared through our TURAS website. And within this, there are real-world examples and tools, particularly that communities can use to support healthcare recruitment, because we've seen a lot of value in aligning community needs and community action with NHS recruitment processes, particularly through the work in Skye. The Living Library itself is a resource that's been developed with Professor Louise Lowcock from Aberdeen University, and it draws on a lot of her recent research. That's really emphasising that community-led approach, and will be publicly accessible for others to use as well. So we hope that again is underpinning and supporting sustainable service delivery in rural areas. The research and evaluation pillar is the one that I'm particularly involved with as well, and underlies a lot of the work across the National Centre. We really want to use research and evaluation to develop a robust evidence base for rural healthcare in Scotland. So our team are engaged in things like gathering and analysing data, but also in supporting that evaluation of programme effectiveness, and trying to disseminate and share insights as well from rural healthcare policy and practice. So we feel this is helping to provide a robust foundation for healthcare solutions that are really tailored to the unique needs of remote and rural, and recognise the variety of different contexts within our remote and rural communities. Just a couple of the pieces of work that we're working on here. Again, within our Turas site, we have developed an online repository which will be added to over time, and we're looking for that to house rural healthcare policy, strategy, but also research and evaluation reports and outputs. And this would, as I say, would be available publicly for practitioners and policymakers to use, for example. And for each resource within the site, we will have a kind of a condensed summary and a little piece outlining how we feel it's relevant to, in particular, Scottish rural health context and landscape. So that is something that we'll be building on over time. We're also, as I've said, engaged in providing evaluation expertise across the other pillars. For example, a piece of work that we're working on just now is an evaluability assessment around rural GP recruitment programmes. And we're also undertaking a research survey of GPs on workforce issues. So again, these are two pieces that we hope will provide evidence that's more widely applicable across Scotland, and will produce outputs, for example, in terms of guidance on evaluation and what type of data we need to put in place to be able to assess rural health interventions. So I think hopefully that's provided a bit of a snapshot across the work that is currently ongoing and the objectives for the centre. We do hope to continue with our work around primary care and community-based services, but would also like to look at whether we can extend our work across acute and social care as well. Obviously, going forward, this is going to be about continuing to keep that focus on resilience and sustainability within rural healthcare, and looking at the research-driven and evidence-based approach to building that healthcare system, and recognising the need to adapt to things like, for example, demographic shifts and workforce challenges. So some of our future plans are to expand our research partnerships and try and deepen those international collaborations to exchange knowledge and learn from good practice elsewhere. We really feel that the exchange of knowledge between partners is one of the core criteria for success moving forward, and want to learn from others' good practice and be able to adapt innovations to the Scottish context. So hopefully that would, help us to facilitate an informed approach to rural healthcare within Scotland. We have a really clear understanding that health inequalities exist within our remote, rural and island areas, and through advancing these 4 pillars, including enhancing the workforce within rural areas, that is helping us move towards a reduction in health inequalities for these communities. So I guess I'd just like to end by saying thanks again for the opportunity to talk to you about the National Centre and share some of our work, and would be very happy to connect with any colleagues here today who I'm sure have some shared objectives and shared goals around rural health. So thanks very much.
Thank you, Sarah Ann. Thanks for that. Some very familiar things there compared with what we're also working on in terms of our areas as well. So there's a really big joined up theme, and I know that we're well joined up from a point of view of links, etc. Can I be naughty and throw in a question to start with, because I'm really keen on understanding it is particularly where your funding comes from. Is it coming directly from Welsh Government, or is it coming from the sort of health boards that run the systems?
So it's coming directly from Scottish Government, and at the moment it's the primary care directorate within the Scottish Government that is funding us to be a national central point for rural health. Yeah.
Great, thank you for that. That's an interesting position to take. So in terms of other questions then within the room, have we got any questions? There's a microphone somewhere ready to run, I'm sure. Any questions from anyone? No. Any questions online? No. Okay. So if there's no questions, then thank you, Sarah Ann. Thanks for that. And look forward to working closely with you going forward in the future. Thank you. Okay. I'm conscious that we're ahead of time slightly. So if it's okay with everybody, just because we've got some online changes happening during the next sort of 5 minutes, if we can just take a little break for 5 minutes, and then we'll come back then to Michael, if that's okay, Mike. Thank you. Okay, thank you, everybody. If we could take our seats again, that would be really good. Otherwise, I shall get told off. I don't want to do that. Okay, thank you. So our next plenary session is with Michael Woods. First of all, before I do anything else, I'd like to congratulate Michael on the £5 million grant that you've got into rural healthcare and rural health in Mid Wales, which is fantastic, and bringing in that sum of money into the think tanks and the thinking through is a massive step, really. So congratulations on that. We will now make a start then, Mike, if that's okay with you. Yeah. Needs sharing.
Sharing? Is that not shared?
I think it needs sharing on the
Yeah,
Teams. It just doesn't seem to be going.
Again,
No. The show pins or not. It's very good. Yeah.
Yeah.
Excellent. Good. Very well. Good morning, everyone. Thank you for the invitation to come and speak to you this morning. And I think it's been good to follow on to Sarah Ann's presentation about the work in Scotland, because we obviously don't have a direct equivalent of that national centre here. But what I want to talk about is how some of the same work in providing evidence to support effective rural healthcare in Wales. There are opportunities potentially to deliver that through this new initiative, which Peter just alluded to a moment ago, which is the Cynhadledd LPIC Rural Wales, the Rural Wales Local Policy and Innovation Partnership. So what I'm going to do is explain a bit more about what this project is, what we're doing, but particularly were there opportunities for us to connect in with issues around health and care within the region, and opportunities potentially for those of you in the room, health professionals, other interested groups, researchers, to contribute to this work and feed into it, because we want this work to be responsive. So just to give a bit of background, this is part of a UK-wide scheme funded by UKRI, who are the British government's research and innovation funding body. And the purpose behind the overall scheme was to support knowledge exchange into local and regional level government, to strengthen community engagement and work towards what they describe as being inclusive, sustainable growth. And I'll come back to that slightly later. So they funded 4 of these initiatives, 1 each in Scotland, Wales, Northern Ireland and England. And we've got funding for 3 years in the first instance, but I think it's notable that the funding body is very much seeing this as an experiment in new ways of working with places, with communities, and seeing it as pathfinders as something which can be rolled out. So there's a clear expectation there that so long we don't do something very wrong in the next couple of years, we will hopefully continue this funding beyond the 3-year period, and certainly that's the basis we're working on. So within Wales, we are a partnership led by Aberystwyth University, also including researchers in Cardiff, Bangor universities and the University of Gloucestershire, the Countryside Community Research Institute firm, but also importantly, partners from beyond the universities. And we're very pleased that Rural Health and Care Wales is one of those core partners. And then a wider group of strategic partners we're also dealing with. We're focused on rural Wales, but we see that as something which is a slightly vaguely defined territory. We have the traditional counties of rural Wales, the tracts of Coffee, but we recognise that some of these interests also spread into other parts of Wales as well. And our overarching agenda then is we twisted that
description we're given by the funders of being about inclusive, sustainable growth, which to us is too heavily economic in its focus, and try to develop it more broadly in terms of supporting inclusive and sustainable development towards a well-being economy in rural Wales. And what a well-being economy does is it prioritises social justice for both current and future generations on a healthy planet in which citizens are actively engaged in their communities. So it's not just about the economy, it's also about wider well-being, and we would very much place health within that and the provision and support of healthy community within that. And as some of you may be aware, a well-being economy is also one of the 4 missions of the current Future Generations Commissioner. And therefore, there's a good alignment with that work. Now, in doing this work, we're also trying to focus on the distinctive context of working in rural Wales and the challenges we have here. So we know that we have challenges of being a very dispersed population, no dominant urban centre. When it comes to economic growth, small size of businesses, limited capital within the region are problems. We know that we've got an issue with youth out-migration, with issues of access to housing, the erosion of public services, persistent poverty in certain areas, and indeed issues around kind of the precarity of some of the majority Welsh-speaking communities. Looking ahead, we know that we've got pressures coming to us from climate change and the demands that might place upon land use in rural Wales. And we also know that we have what I've said could describe as a fragmented governance structure, by which I mean that the local councils, indeed the health boards of other organisations, are comparatively small compared to those elsewhere, and that limits the capacity to act and often to have the analytical capacity to develop evidence with the film. So those are some of those challenges, and that tends to, perhaps the ones I focused on there, emphasise the economy part of the wellbeing economy description, but I think it's also important we think about the well-being part of that. And this is where I think the connection to health and healthcare comes in. Because in addition to those challenges I've already mentioned, we're also very aware of particular challenges for delivering quality healthcare in rural Wales. There are specific health demands which come from there being a disproportionately elderly population in our region and in many of our communities. And those challenges are increasing as that population becomes increasingly elderly in many ways. There are costs of delivering healthcare and maintaining health services in this dispersed rural area, where we have limited local populations to justify that the costs of those services. Equally, we are in a situation where we're having new technologies, new ways of delivering healthcare, which in principle favour concentration in larger centres where you've got the specialist personnel to deliver that. And that grates against perhaps a dispersed model of healthcare provision in a rural setting. And then we also, as we're very much aware, have the challenge of recruiting health professionals within this region across the board of different health occupations. So those are challenges we've also got, and we want to try to think about those. So we have, as I mentioned, some of our focus about economic challenges, and what I have here is a kind of model which takes on previous work we did, where we applied the 7 wellbeing goals in terms of what that might mean in a particularly rural context. So again, some of those about the economy, but it's also about the wellbeing goal of healthier Wales, translating that into having accessible and equipped healthcare in our region, but also thinking about our Wales coherent communities being about empowered and age-balanced rural communities. And again, there's a health dimension to that. Fair access to services, housing and jobs as part of a more equal Wales is about, again, fair access to healthcare. And a resilient Wales being translated and seen as being a strong and resilient rural communities. That resilience is also has a health dimension, the resilience to overcome health shocks like the pandemic in COVID-19. So I think what we're trying to make here is that these things are integrated. And when we think about some of the challenges facing healthcare in rural Wales, they actually are in many cases similar to those facing other sectors as well. And there are knock-on effects as well. So, for example, this comes from a conversation I've had. changes to public transport system, particularly the erosion we've seen of bus services in recent years. This is by presenting a problem for delivery of healthcare for health boards, because it makes it more difficult for many rural residents to get to those health appointments. And indeed, the planning of that health delivery has been based upon a transport system which no longer exists in the same form it did when that planning was made. So how do we adjust to that? Because health is linked to public transport, and the same issues with public transport also apply to other service deliveries, and they present issues for employers and economic development as well. Social isolation and how that maybe links into issues around mental health, again, are of concern to health providers, but they're also of concern to other agencies in the region. It's interesting that when we spoke to the Police and Crime Commissioner, he was concerned about social isolation in rural communities as well. So it's a way we can start joining up the dots between what's happening in terms of rural health and care and what's happening in other sectors in terms of rural policy. One of the ways we do that is by having a number of themes around how work is organised. And you see some of these, again, emphasise the economy or the environment, but they include this theme of enhancing wellbeing in place, which is one where we particularly put health inverted sit with. So these themes shape our work, but we also structure in a way that around each of those themes we have a thematic group, which bring together researchers working on that topic, not just within the partnership itself, but more broadly from Welsh universities, stakeholders, practitioners, community representatives. These are chaired by both academic and non-academic co-chairs. So Anna is one of the co-chairs of the Enhancing Wellbeing in Place group. And the purpose of this is to get together to share intelligence, to raise issues of concern for those who are practitioners in delivering policy, and linking that perhaps up to evidence and expertise and research that is being done, but also identifying where there are gaps in that evidence base, and as such, proposing what we can do for the partnership in order to fill those gaps. So in a sense, we have a structure in which we have thematic groups which are commissioning our work. And then we have a series of mechanisms for delivering that work, which are all going to be responsive. These are not about academics deciding what to do. This is where we are trying to do research and gather evidence on issues which are brought to us by stakeholders and practitioners and communities. So just to mention some of these briefly here. So we have, for example, a work stream around innovation labs, which is about developing and testing innovative solutions to overcome obstacles to change. And again, we have one of these in each of the themes we have. These will bring together participants and different stakeholder groups. They'll meet together, they'll kind of discuss a desired change, but then also think, what are the obstacles to that change? What are potential solutions to get around those obstacles? And then take one of those ideas and intervention and test that over a 12-month period and evaluate how that works. So again, the Enhancing Wellbeing in Place Innovation Lab is being led by James Lewis in Cardiff University, who used to head up a lab there as a public services innovation centre, whose background is as a health sociologist. He's currently working on projects like Decipher. So he's, although that theme potentially is broader than health, he's very keen to focus on health in this work of his innovation lab, and to ask questions about what can healthcare, public health innovations and interventions, how can they be tailored to particular needs of rural Wales? And some suggestions there which might come up. The group itself will decided ultimately what to focus on, but that could be about innovations to deliver healthcare in rural context, about how we address some of the rural dimensions, the social determinants of health, social isolation again, or how again we actually encourage greater participation by rural residents of farmers and others in kind of preventative forms of healthcare and health provision. So again, we're looking here to bring people into that lab and for, again, a partner organisation to test a host of intervention. Secondly, we have community action-led research, where we are working with individual communities. And instead of us going in as research and doing research for that community and coming out again, we're saying to those communities, what's important to you? What do you want to do, and what do you need to know to do that? And therefore, how can we actually help you to do some research to bring together the evidence you need to work on this problem? So we're supporting those communities and empowering them to do research themselves. We're starting with 5 pilot communities we've got, and then we'll be opening this out to 10 further projects next year. So again, it might be health and care, the focus of some of this community-based research. It could be about identifying the needs for healthcare in a community, understanding how the residents of that community access healthcare, get to that, some of the obstacles involved, and how to overcome them. Again, it might be about social isolation and mental health, or links between health in the community and things like air or water pollution. So again, we're looking for those ideas to come in. We're also doing some surveys to update our evidence base. Again, a number of different kinds of surveys over the next couple of years, but the one I'm going to particularly mention here is a survey of households in rural Wales. We'll be doing this online, phoning up people, about 4,000 households. And this is part of the update of the survey done just over 10 years ago, which included questions on things like how people accessed healthcare, whether they had a long-standing illness, but also things like that if they were ill and unable to bed, were the people around them they could rely on to help? What kind of informal care was there? So we may want to update some of those questions, but again, a question, are there other topics we should be asking questions about? Is there other information it would be useful to you to know? And similarly, more broadly, what we want to do to draw together data from different sources, create a single hub online to access evidence to support policy and practice in rural Wales. What kind of data from a health point of view should we be bringing together? What exists out there we can bring together? Doing analysis of that data, things like census data, which is now coming out. What analysis might we do of that census data, which can help you as healthcare providers in different ways? And then just to finish this off, we've also got some kind of short, quick turnaround projects, which are again addressing issues raised by our thematic groups, and a whole series of public engagement work, which will include also dialogues of using all the evidence we've collected to address some of these tricky issues facing rural Wales. Cross-cutting all of that is also a strong emphasis on equalities and inclusion. We don't just want to be speaking to the usual suspects. We don't just want it to be the large organisations who are dictating what we do. So again, we're trying to reach out to different groups, often those who are underrepresented, those who are hard to reach, making sure we listen to them and what concerns them, and providing means for them to get involved in our work. I'm just going to finish there with an invitation again to contribute to this work and get involved, whether that's about kind of applying to be a member of our Enhancing Wellbeing and Place thematic group or the other thematic groups, and helping to share that work programme that is coming up. Maybe expressing an interest to be involved in the innovation lab around this project, thinking about potential innovations for healthcare in rural Wales. Working with a local community or your local community and potentially submitting a application proposal to do a community-led research project on something which really concerns you and your community about health. And then feeding in household, again, data needs in terms of questions, evidence you want through analysis, and potentially again, working with us in terms of public engagement. We can bring resource and organisation to help organise events and workshops, discussions around some of these matters. And we're open to working with a range of organisations to do that. If any of that is of interest to you, please get in touch with us through the email there on the screen at lpip@ama.ac.uk. Thank you very much.
Thank you, Michael. Don't run off just in case. In terms of the themes that we're picking up from yesterday and driving into today, that working with our population and not prescribing to them, coming in again there, isn't it, in terms of making sure that we get people involved and we don't just expect one pill to fit every illness. Any questions from the room before I ask about online? Anything from anyone? No. Anything online, Anna?
No.
nothing online. So thank you, Mike.
Thank you.
Thank you for that. Again, really important, isn't it, when we start to link these things up and these themes of the discussions that we're having here around and with our population, not in isolation, not designing something as professionals and expecting people to kind of swallow the pill. I think it's a really, really important theme, really, and also about empowering our communities, strengthening our resilience, developing our local networks and local infrastructure. Really important stuff. So really good work there. Encourage everybody to email in and inundate the inbox with wanting to get involved and wanting to work on that, because that's really kind of going to be really vital in terms of going forward with our populations. So we are again, I think, slightly early. Am I breaking again, Anna, for a few minutes?
Yeah, it's
Yeah.
11:15 minutes.
Yes. Okay. So we're going to break again, if that's okay with everyone, for a few minutes. So posters, etc., and networking, and then we'll come back in again for 11:15. Thank you. Okay. Yeah. Okay. So we're going to move on to our next plenary, if that's okay. And I think Gwawa has joined us online. Getting the nod. Yes, I'm getting the nod. So this is an exciting dual act, double act around this. So we will be having two presentations in one here. So there's a little bit of a changeover in the middle. The first one is online, so it's presented online. Second one is in the room, so you will see some running around and shuffling of technology whilst we change over from that. Again, welcome to both Gwawa and Jim. And if we can kind of do the double act, and Jim, if you're happy to come up when Gwawa's finished, then we can just keep the flow going, if that's all right, and then we'll have questions at the very end for both of you, if that's okay. So Gwawa, I'm going to hand over to you, and thank you.
Hello, thank you so much for inviting me to talk about farming at the Cardiff City Mental Hospital. I worked at what became Whitchurch Hospital later on for many years as a mental health pharmacist. I was always interested in the history of the hospital, and I'm very excited to have the opportunity to tell you a little bit about the farming history at the hospital. So here we go. Hope this works. Can you see it? Hopefully. So the hospital was a large mental health hospital in Cardiff. For those of you that are familiar with Cardiff, it's close to the M4, and we've got the big Corriton roundabout just a couple of 100 yards away from the hospital. So just to show you where we had two farms, we had Cynhadledd farm and we had Cynhadledd farm. So we've got the old map on the left. These are from the National Library Scotland maps, which are great. And then we've got the modern map on the right. So Cynhadledd farm was close to Tongwynlais, where Castell Coch is, for those of you that may be more familiar with Castell Coch. So Cynhadledd is now part of the Corriton roundabout, the very large roundabout to come into Whitchurch. And then we've got Cynhadledd farm that was close to the actual hospital buildings. That is now just a ruin and all covered in just brambles. And then you've got the hospital there on the horseshoe shape. Okay, so just to give you a pictorial an aerial view, to give you more of an idea, this is the main hospital. You've got the water tower there in the middle right of the picture, and the whole hospital wards and buildings. And then the arrow there is showing Cynhadledd farm. Unfortunately, we have absolutely no photos at all of Cynhadledd. But there's Cynhadledd, so you can see that it's pretty close to the main hospital. Now, the farm was very controversial. Even before the hospital opened, there was always some thing in the paper about the farm and how much it cost, and so it's attracted an awful lot of controversy. So we have here, hope you can see the picture of the cartoon. It's a Western Mail cartoon, and it shows a number of pigs lying on sofas in very plush surroundings with chandeliers and a gramophone with music. So this was published just under a year before the hospital actually opened. So it was published in 1907. So it was when the hospital was being designed and built. So you can see, you know, they were complaining about the piggery costing £1,000, which was, you know, a lot back in 1900. 1907. And then more controversy to follow. Just a month before the hospital opened, we opened in April 1908. So in March 1908, we had the Secretary of State objecting to the farm buildings because they were too large and far too big for a hospital, and they were going to cost a lot of money. So the request was made to go back to the drawing board and come up with something smaller and cheaper. We're very lucky as a historical society to have a red book of cuttings. Somebody from before the hospital opened right up until the First World War meticulously cut out relevant newspaper cuttings and glued them all into a large book, and we're very lucky to have that. So this is where this newspaper clipping has been found. I'd like to introduce you to one of the farm bailiffs or farmers that worked at the hospital. A few years ago, I was contacted by the Beach family, and it was very exciting because we'd never had any contact from anybody involved in the farming side of the hospital previously. And Mr. Alfred Beach was employed in 1926, so a couple of years after the hospital opened. He was previously in London, in Croydon, in a mental hospital there. He was picked for Whitchurch out of a very large number of applicants, and the paperwork said that he had excellent credentials, including army service in the First World War. And here he is, Mr. Beach. And the photo is by kind permission of the Beach family. A bit further on again, we've got a later photo here of the actual Cynhadledd farmhouse to show you. It looked a lovely farmhouse, and it was a very productive farm. The 1938 hospital annual report showed that they produced 120 tonnes of potatoes. They had dairy cows, they had sheep, pigs, and poultry. So it was very busy. The patients, particularly the male patients, would go over and help on the farm every day, and you know, they prefer. So many of the patients preferred to work outside rather than be inside, so they picked farm work. Just to go back to the pigs, we've got another lovely photo by the Beach family. We've got a sow there with her piglets, and you know, the pigs did, after all the controversy and the lounging around, the pigs did very well. In the 1937 report, it said that they had very good prices for the pork from the hospital, and that the farm pigs are much sought after in the open market. And some of our historical society members actually remember when they were working at the hospital in the 60s. I remember going over to the farm and holding the piglets. So, you know, it was a very important and essential part of hospital life. So the pigs were actually prize-winning pigs as well. We've got a newspaper cutting here from 1937, Christmas time. They took the pigs to the Ely Cattle Market Christmas show, and they won first prize. The picture is actually from the Glamorgan Archives, which is our local archive in Cardiff. I mentioned the red book earlier for the cuttings. Well, Glamorgan Archives have got the one that follows on from that, from the First World War up to the 50s. And this is where I found this lovely cutting of the pigs there winning their prize. So that wasn't just the only show, it's just the one we've got a photo of. So they had various prizes at all the local shows within Cardiff. They had breeding cows, they had bacon pigs, and they also had porkers. So they took it very seriously. It wasn't kind of a novice production. It was professionally run. So just to kind of follow on the history of what happened. So in November 1954, sadly, the pedigree cattle were sold. This is from what's called the Top Farm, which is the name they used to use for Llwyn Mall. I presume they called it the Top Farm because it was, higher up of the two farms. So that must have been a really sad day, selling off all the cattle. And then following on from this, we have the annual report for that year mentioned that it was the Ministry of Health policy that the farm stock and the equipment were all to be disposed of, which is what they'd already done. So they'd done what they were asked. And then they were still waiting to hear what was to be done regarding the actual farm. So at this point in time, 1954, they were converting the cattle shed into piggeries. So it looks like they're going from a full kind of farming operation to just concentrating on pigs. And they've got 150 pigs at that point in time in 1954. And then I found a general newspaper article about Welsh hospital farms, which is quite interesting. So this is from the Western Mail and South Wales News. I hope you can see it. It's quite difficult to read. So this is February 1956. And it's basically saying they're going to sell off all the hospital farms. But the bit I wanted to show you was the profits and losses. So in 1954, 1955, interestingly, a number of Welsh hospitals made a profit, a large profit, the farms now, and they still decided to sell all of them. You'd think that maybe they'd consider selling the unprofitable farms, but no, they sold every single one of them. Despite, for example, there we've got the North Wales Hospital in Denbigh, made significant profit of £4,000. The South Wales Sanatorium in Talgarth, again, significant profit. Penafal in Abergavenny, nearly £2,000. The Mid Wales Hospital in Targarth, over £1,000. Whitchurch Hospital profits are quite low, £150, but I do wonder whether that's because all the cattle were sold off a couple of years before, so therefore the amount of profit to be made is going to be smaller. And then there's obviously hospitals below, like Caerleon and Newport and Bridgend, not making a profit. But anyway, they decided to sell off all the hospitals regardless. And then another sad day was when all the pigs were sold. Now, I think that this would have been from the Cynhadledd farm. And 1968 was when all the implements and all the pigs were finally sold off. I wanted to bring you right up to date, just to finish off, just to tell you about something that's currently happening, which is I find quite interesting considering the history of Whitchurch and the farming that happened over the years. So the main hospital is closed. It closed in 2016, but there are some rehabilitation facilities for patients with mental health diagnosis still just outside the hospital. So they're called the Park Road houses, and these used to be staff accommodation when all the staff lived and worked in the hospital. So the staff houses back in the late 90s were converted into patient rehabilitation houses. So at the back of the houses, there are about 2 tennis courts worth of land. And Owen Bagler, who's the current manager, came up with the idea of transforming this land from just grass into a garden and a vegetable plot. So they've got flowers and vegetable, and the patients and the staff have had huge benefit from being involved and being outdoors, and they've been presenting it and they've been winning awards, and it's just a lovely thing to end on. That despite the sadness that the hospital farm is no longer, they have used the kind of the thinking behind it and the benefits still today. So thank you very much. And if you wanted to know more, we've got a website and the usual social media channels, and happy to answer any questions later on.
Thank you for that, Gwa. Thank you. And some interesting mentions of Talgarth and places that are quite close to home for some people in the room here. So, Jim, do you want to whiz us through now up to date in terms of where we're at and what you're up to? Thank you.
Oh, can you hear me? Yes, great. I've got a very quiet voice, so luckily this thing's really good. I'm from Clinview Care Farm, which is in North Pembrokeshire. If you Google it, there's loads of stuff on YouTube. Which one?
That's forward.
That's forward. This will just be the greatest hits of what we've been doing. But if you have a look on YouTube, there's loads of films, or come and visit as well, because we love it when people come and visit. We like stealing people's ideas, because you know more about this stuff than I do. But anyway, I'll zoom through it. Clinview's my family's farm. We've been farming there. That's not doing anything. Oh, there it is. That's the first one. We've been farming there since 1750, so we've been there a long time. My family have been in the area for over 1,000 years before that, so it really feels like home. Back in the 1800s, my great ancestor, William Henry Lewis, married well, so somebody who had a lot of money, and so we built a mansion. And then all the years since then, up till about 17 years ago, any money we made to try to keep the roof on the place. And 17 years ago, I gave up and we ended up selling it. But back in the olden days, oops, oh, there we are. Farms were real community hubs. There was loads of people working on a farm. Now it's all this thing. There we are, that's better. And people would work together. You knew your community, you knew your farming community, you helped each other out. And when it's harvest going on, everybody would come down. It'd be a real community event. Farming's changed over the years, and when I stopped farming properly about 15 years ago, it was really me and my dad doing the farm work and our neighbour across the road doing the big contracting work. And it was very isolating, and the mental health pressures on farming communities are massive. So when we get to the end of this story, sometimes you'll understand why I look for a bit of peace, because you don't get isolated on the care farm anymore. Back in the 60s, my gran used to do holidays, and she was quite far ahead of that in rural holidays. In the 80s, my mum started doing accessible holidays in one cottage called the Muse at the end there. And back in the 80s, very few people were doing that. We were trying to make the countryside more accessible for disabled and vulnerable people. So really everything we've done is based on her ideas and her skill at talking to people, saying, what can we do better? And really nicking their ideas and building everything that we're doing on what people say about true community engagement and all of that. I knew I wanted to live there. I knew I wanted to be on the farm, but I didn't want to do it yet. So is that going to do anything? Not yet. So I went to catering college to learn how to run a centre, and I hated that. And so got involved in coaching cricket and ended up coaching cricket in Kenya, where I was for 2.5 years, which made me realise how lucky we are to be living in West Wales, experiencing all sorts of stuff there, and trying to bring those ideas back home again. And it's there that I saw I understood the first effects of climate change with El Nino and El Niña and famine. And people would come to Nairobi, where I was. They'd come as refugees from Sudan and Somalia and Ethiopia and Eritrea, and then from the genocides in Rwanda and Burundi. And seeing these sorts of things happening in real life made me realise I didn't want to spend the rest of my life just coaching cricket. I wanted to come back home again and try and do something worthwhile with our farm, because having a farm is a hell of an asset. So in 1998, I came home and we converted the farm to organic. And farming's really hard, in case you didn't know. But it was really rewarding in many ways, especially when we got other groups coming onto the farm having young people getting involved in farming, even people who lived up in the village. Newchapel at the top of the hill, a lot of those youngsters had never been on a farm before. So we knew that we wanted to try and be as socially inclusive as we could on the farm, as much as possible, based on my mum's ideas of making it as accessible for everybody as we could. So we went down to the local authority, said we wanted to do this, wanted to convert some more farm buildings into doing respite accommodation, so that families with a disabled member would have a break, and their person would come and stay with us with support, getting involved in the rural stuff, and they would have a few days break. And before that, the other opportunity was being stuck in a care home, an old people's home. And if you're in your 20s or 30s or 40s or 50s, you don't really want to hang around with the oldies. You want to be doing other stuff. So that's what we were trying to do. And we ended up we were in Objective 1 area for European funding then. Do you remember those days when we had European funding? Good times. We ended up converting some more of the buildings, and we used timber to heat the cottages. We had a reed bed for clearing up the toilet waste, and we tried to take the organic philosophy out of farming into everything that we were doing. And we became the first business in Wales ever to win the Queen's Award for Enterprise and Sustainable Development. And this was in about 2004, when the King was just a prince and where I was a younger man. And so we did that as a way of boosting PR of what we were doing. I'm not a monarchist, but we needed to use him as a way of getting understood, because we were a bit far ahead of the game then, really. And so we were doing the respite stuff, we were developing all those kind of things. And then in 2011, we started a day service as well. And that was from going to talk to carers groups and talk to the people that were coming on respite and saying, we've got a farm, we want to do more. Because people who were coming on respite were saying when they weren't on respite, they really didn't have much to do. They were staying at home, they were going to the charity shops, they were doing pretty limited things. So we had a visioning day where we invited everybody that I've met over the last 12 years to this day to say, what can we do with the farm? Where should we be in 2014? And then we worked our way back to find out where we were, who we could work with, who were the allies, and how we could get to that point. And it was really then that things started kicking off in a good way. Linking up the University of Bristol, they'd done a study to show that there are microbes in soil, that if you manipulate it, you feel better. You don't even need to dig a garden. You can just sit there watching telly, playing with soil, and it will boost your well-being. And so it's trying to feed these things into what we were doing. We're not therapists, but what we provide is a therapeutic use of nature in the countryside. And our very first person on the day service was Sandra. She loved knitting, but before she got stuck in with the knitting, she'd walk into the woods with Bernie, our first staff member, to feed the pigs. And back then we had outdoor pigs and we had Welsh black cattle, and we were making charcoal in the woods and growing a lot of cereals as well. So we were balancing that off against people coming in on holiday and against the day service. We also had chickens, the very free range, perhaps a bit too free range, but that was a good. And bit by bit, my time got moved away from the farming and more involved in the care farming side of things. So now we don't farm anymore. We have one field that we use for the care farming bit, and we've rented most of the rest of the land out to an organic farmer, Heaven Evans, who's a far better farmer than I ever was. So it's better for the land as well. And we have lots of people who come to the farm. We stopped doing the respite in the end because some of the people who were coming on day service, who we got to know, we discovered that they lived in appalling situations. The very first person we were supporting was living in a damp caravan above Newcastle Emlyn with dripping walls, haunted by the ghosts of his parents who'd both died in the caravan. So he ended up moving in, and bit by bit we stopped doing the holidays, and there are now 9 people living in full-time supported tenancy on the farm. And when I talk to other farmers who back in the 80s and 90s diversified into holiday cottages, like we were all advised to do, who cottages sit empty most of the time, we encourage them to look at this model. You can work with a local care agency to provide the support. You'll have the full year round rental accommodation. You don't have to worry about cleaning every Saturday. You don't have to worry about horrible tourists doing stupid, idiotic things that you'd never imagine. And you have a community on the farm of people that you can get to know. So it's a really sound business model. We have a turnover of over £800,000 a year now. We have 41 paid staff. We pay nearly £700,000 a year in wages to our local community, which in our patch makes us a significant employer. And last year we had 0.5% grant. The rest of it was all winning council contracts to support the people. And these guys who live on the farm could be living anywhere. They could be in supported living in Ammanford or Cleffley or wherever, but they choose to come and live on our farm in one of the cottages. So it's a robust business model that's sustainable for good. And when we talk about sustainability environmentally as well as economically, this kind of care farming model ticks every single box you've got. And we're providing organic hay, and we're providing organic vegetables. We have a big vegetable patch ourselves. That's spawned 3 other community gardens up in the North Pembrokeshire area through Fernon Community Resilience Group that we set up just before lockdown. So this model of keeping disabled and vulnerable people at the heart of food production is going to be so important in the years to come as our society is increasingly challenged by climate change. And when you look at societies over the years, when they teeter and when they rock and they become more difficult, more dangerous, it's the vulnerable people that get hammered first. And the people that we all support are going to be the ones that we need to support even more focusedly in the years to come as climate change changes our society even more. The election yesterday, with Donald Trump coming in, is potentially a disaster for all of us. And we have to focus on developing our communities now and not relying on the governments to support us, because they won't have the tools to do it. And care farming, we demonstrated over the last years, does that. It does it well, and it doesn't patronise. It does it properly, engaging people to the maximum of their ability. So yeah, this is a community garden. It's also really fun hanging out in the sun with people that you like. And that's an important thing too. Yeah, people do what they can. You know, some people, everybody works hard, but some people get more done than other people. And that's okay. And growing vegetables and being able to take the vegetables home at the end of the day or bring them down to the community kitchen. We make lunches every day for people who are there too. And there's nothing better than picking a carrot, going down, cleaning the carrot, chopping it up and eating it. You know, it links all the gaps that many times, you know, the sort of a link has disappeared. And, you know, it's a fantastic harvest as well. We got really good land. And even people who don't really like gardening, we had this trolley at the end of the drive. And Wendy really liked that. And her job was then painting up that trolley. So she felt she contributed to the whole thing as well. Garon there has limited movement. His physios and his OTs were saying he needs to do all these stretches, you know, all this sort of stuff. And he didn't want to do that, but he liked contributing. As he's sorting out the potatoes, he's doing all his stretches. You know, not in a patronising way. Somebody's got to do it. And that's the way that he contributes. And care farming is so cool in that it can change. We can adapt anything that we do to meet people's needs according to their care plan. So he doesn't feel patronised. He's, you know, a vital member of the team as well, doing his stuff. And Peter wanted me to share this with you because he really liked the picture. So I don't know what it is, but it's good. We had another idea of, you know, sometimes too many cakes. But if we attached a food mixer to the back of a bicycle, then we could put cream in it, and then you could cycle a few miles and turn the cream into butter and use the butter then to make the cakes. So you're burning off the calories before you actually eat the cake. So yes, that was fun too. And then just being outside with animals is a wonderful thing. If you haven't done it, you should do it. Yeah. I just like some of these pictures. They're really nice. Yeah, even hanging out with, that's my dog Otis, who's just a bit nutty. And when in the autumn time, then we've got 250 apple trees and we harvest our own apples and we make apple juice. But we also have an apple juicing service so that people who have apple trees nearby can bring their apples in. We'll juice them all up. If you try and store apples fresh, they'll tend to go wrinkly within a few weeks and they'll all be gone within a month. But if you juice the apples, then the juice then lasts for a year. And it's local stuff. You're not importing it from overseas or anywhere else. So it's reducing the carbon footprint. And our guys are involved in the picking and the juicing and the labelling and then the marketing of it and delivering. Jason today, his job on a Wednesday morning is going around delivering apple juice. So that's, you know, a really worthwhile thing. And it ticks all your boxes and all the way around. Another project we have is charcoal making. We've been doing that for a long time. And this is the best charcoal you're ever going to find. You know, you can light it from a match. You don't need artificial fertilizers or anything. Oh, not fertilizers, lighters. And it isn't imported stuff from the Amazon or West Africa. Like the apple juice, if you test it, if you have taste test our apple juice against anybody else's apple juice, you know, it'll be up there. It'll be up there. And all our guys are doing things that are meaningful. It's not patronizing. It's, you know, quality stuff. Hewell had never made bread before, and he was in the kitchen one day and said that. And so he's making bread, and his pride of being involved in that was huge. And then working with the national parks, doing tree planting, which we've done a lot of on the farm over the years, and then trying to encourage other people to do that too. They're all things that people can do. One of our staff members, Adam, is a bushcrafter. That's his love. That's what makes him sparkle. So we, on a Friday, it's not during the winter, but during the spring and summertime, on Fridays, we do bushcrafting in the woods. He looks forward to that day of coming in and doing that. He shares what sparkles him, and it sparks other people to play games with fire, to do tree identifications, to do foraging, to get to know the woodland a whole lot better. And if you're looking forward to doing that on a Friday, it's a reason to get out of bed for everybody. And on other days, other people do different things. But for a few of our guys, that's the big thing. That's what they love most in the year. We work with the British Hen Welfare Trust as we're the West Wales rehousing point. And every month I go to a battery farm in England, pick up 240 hens, bring them back home again. And the trust has already found homes for those 240 hens in West Wales. So they get distributed. So in people's gardens, they've got a few hens that would have been slaughtered otherwise. 2 weeks ago, I was at a farm in Lydney where they had, it's just astonishing, intensive chicken farms, and they had tens of thousands of hens. And on the day we were there, we brought 1,000 hens home, or 240 to our place, and the others went elsewhere. The following week, the rest of those hens were slaughtered because they were 18 months old and their productivity goes down slightly and they don't work in a conventional farming system. But by doing this, we can get good quality hens to everybody in their gardens, and it stops that sort of system. And it's also a great educator. And these guys, Tink and John, they love being at every event that we have, talking about hens, talking about chickens, talking about quality of eggs and the awfulness of intensive farming. So care farms can be a great education as well. Tommy likes making benches, so that's his thing. We have a project called The Really Good Idea, where we get all wheelchairs and mobility aids. We've been doing this about 12 years now as well. And we fix them up. And we work with, this is the WI. We sent loads of stuff to Calais. We send loads of stuff to Calais. We sent loads of stuff to Kos in Greece as well when the refugees were coming across there. The WI then were making loads of hats and jumpers and things for kids. And we put them in a shipping container and we send them off to wherever they need to go. Hewell, who's one of our residents, he went to South Africa. He's been there twice. When the containers got there, being able to give out wheelchairs to children that have never had them before, and Zimmer frames to a group of mamas, and all sorts of kit that we get from the NHS and from care homes and things, stuff that's abandoned. It's cheaper for them to buy a new Zimmer frame than it is to clean it. And so they just tend to scrap them. So linking up with this project, we're keeping the things out of landfill. We're feeling good about ourselves. Our well-being is boosted by fixing this stuff and putting it in the container. Then it gets to other people elsewhere. And it ticks all the boxes. It's a massive win. And that's an extra little project that can go on the back of care farms. We also do lots of campaigning stuff with Disabled Access Day and other things. And we're working with Kwame, who is a surf therapist off the coast, getting involved in the Blue Gym. He set up his project, not out of time yet, nope, still doing right. He set up his project working with homeless veterans in Aberystwyth who didn't want to engage in therapies with the flickering lights and people who didn't understand what they were talking about. And surf therapy is a fantastic way of being brainwashed by the waves. You get switched off from all the thoughts. And soldiers, it turns out, are really good surfers because they are good at being told what to do. Now, people like me, I can't surf, and he tells me what to do and it just doesn't work. But it's a really good tool for engaging with veterans. And he lets us, our guys get involved in it as well. And it's just really good fun for folk who've never really been in the sea before. You don't really go much above waist deep. But it's a great experience. It's something different the Blue Gym or nature can offer as a therapeutic tool. And we've won a bunch of stuff over the years as well. There we are. A couple of years ago, we won another Queen's Award. Hooray for us! King didn't come down that time. That's right. But we wanted to do it because we wanted to be taken seriously as climate change is coming down. Care farms are so important. Local food production is so important. Finding ways of making sure our vulnerable people are not pushed aside is so important. And as we've seen in Florida with the storms, and we've seen in Spain with the floods, and if we've seen pretty much in every country. It's not a fantasy thing, it's a real thing. And we are not preparing enough for it. I've done it. The next project idea that we've got is talking to our guys. Some of our fellas love washing cars. Some of our fellas love mechanics and things. Near Kilgarren, the local village, there's a petrol station that's been for sale for about 3 or 4 years. We're doing a feasibility study to see if we can buy it. It's got an MOT garage on the back. We could offer ways that people could get involved in doing MOTs, maintenance on cars. We could find a way of, I have a minibus that runs on vegetable oil. We could convert cars to running on vegetable oil. All diesel engines could run on vegetable oil. I have a friend who goes around to chip shops and picks up vegetable oil. You clean it and then it runs it in the cars. This could be the next stage for our people we support to be doing mechanics and other things like that, learning all sorts of skills and easing us away from the petrol related industries, moving on to the next stage, climate change. And in a village to have a petrol station is such an important thing. It can be a real important hub. So it's building wider communities, wider community resilience. That's the thing. And instead of just talking to ourselves all the time in the climate conversation, we get to talk to the petrol heads and we expand the conversation out further. And I'm talking too much about it because I'm quite excited about it. We'll see what happens on that. There we are. And that's just a big thank you for listening. If anybody would like to come and visit, please do. There are films on YouTube. I've got some flyers if you want as well. But there we are. Thank you very much.
You must stay up in case there's anything.
Thank you for that, Jim. And interesting, isn't it, the history and watching the sort of dissolving of what now, Jim, you're pushing forward and making sustainable going into the future. So, one of the things I think we've got here is we've got to learn from history and make sure that we don't repeat the same mistakes in terms of what you're offering and where you're going, really. So, any questions from anyone in the room before? There's a few. So, should we start over there at the back then? Michelle, thank you.
I find it really interesting, isn't it, that really when we're looking at those sciences, it's occupational therapy, and it's really interesting and really rewarding to hear that we're coming back around. We aren't just people that give out equipment and get you out of hospital. This is what we've always been doing, but we can't do it by ourselves. So we're so grateful to people like you who are showing that people can be well, stay well, and recover through using their hands, being connected, being involved, meaningful activity, being occupied, really. So a bit of a shameless plug, but also I find it really interesting that we're stepping away from this medical model and coming back to something that we've known for over 100 years. So thank you so much for what you do. That was really interesting. Thank you, Gwal.
Thank you for that. For those people online, that was a plug for occupational therapy and also an acknowledgement of this sort of thing has been wanting to be pushed forward for many years. So I have to repeat the questions because online we can't hear it. So there's a question here, I think, at the front.
Hi, Jim. Really interesting, really intriguing, rather, I would say. I'm Soham. I'm an MSc Biology student at Aberystwyth. One thing I was really intrigued about understanding, how do you do community mobilizing in terms of bringing rural communities into programs like that, right? That's one aspect I was really intrigued to understand. The other aspect was vulnerable population, right? The reason I'm asking this question is I come from a context of South Asian countries, and with a very limited understanding of what human psychology is, we are very short-sighted, right? If there is no food on the table today, doesn't matter if you tell me a year after today, I'll have a bounty full of things, right? So how do you convert people into understanding? this is the value addition if you come to our field and do the kind of work that we're providing. So it's something that I'm interested to understand.
Yeah, thank you for that. For online purposes, that was a question about how do you really harness the community, how do you get people involved? Yeah.
Thanks. Well, we've been trying that for years, engaging with people. To begin with, we did coffee mornings on the second Friday of every month for about 10 years for different organisations, from the local hedgehog charity to mine, to any group that we could think of, to local village halls, or a child that was doing a fundraiser. So we were doing coffee mornings for other people all over the place. For us, it was brilliant PR. We didn't make any money on it, but we enjoyed making cakes and making tea and meeting people. So really, it was our message was, we are a venue. We want to help you. Whatever your cause is, we will try and help it. For us, it was shameless promotion, because we're the good guys. Come on, we'll help you out. And that was fine. It didn't matter. And so over the years, then we became known as that kind of place. I didn't say, actually, we just started selling the farm, doing a community share offer, so that the farm will forever stay as a community farm. And the main buildings and all that kind of stuff, that share offer's just finished. It's been successful. And in the years to come, then we're hoping to include more of the land and the woodlands, so that the farm stays a true community hub. And it's by demonstrating that, then people can see it. And we've been around long enough to know for people to know that we're not making it up. We're sincere in what we're doing. We're not just in and out. That's the thing. And the thing about, I don't know the answer to getting more people engaged in longer term vision. We're just keeping on doing what we're doing and giving people the opportunity to talk about what they do as well. And that's so important, because there's so many good people doing good stuff and the media doesn't promote it. So it's, yeah.
Thanks for that, Jim. I thought one more question from, and then we've got one online, I think, haven't we? So, Michael.
Yes, thank you. Well, quite probably up here. I think two very good understanding presentations there. Jim, I was very interested, because I think I first visited the curveball in the Netherlands about 15 years ago and thought it was a wonderful thing. And I've come across some other examples and trying to think whether I come across another example in Wales before. So are you aware of other curve farms in Wales? So in that sense, I'll position that. And then particularly with yards, what struck me is that we were able to offer so many different things. There's lots of different, the orchards, there's the chickens, there's vegetable growing. And I'm wondering about your sense of the ease of converting from a farm into this. I mean, was your farm something which had a mixed farm with different things already? Or have you created some of that specifically for the curve side of the work, and that sense of how, in a sense, how easy this could be, or how accessible this is as a model for other farmers to potentially roll out?
Yeah. Lee, do you want to say that?
Yeah, if I can. Yeah. So this question is around how easy is it, or how easy would it be for other farms to be able to be working through into a care farm arrangement in terms of the future model?
There are lots of care farms around, and a lot of them are linked to social farms and gardens, which is kind of the overseeing organisation. They're brilliant. You'll never find a care farmer that doesn't want to talk about the work they're doing. We just all talk too much. Most of us say, though, if we'd known at the beginning how hard it would be, we never would have started. But then we thank God that we didn't know, because we're quite happy where we are in the end. They have a code of practice that helps people get involved in all of this, letting farmers know how to do it well and all of that. So they're really great. They're based in Cardiff, but I think they've got an office in Aberystwyth as well, and then in England, and then Netherlands. Netherlands were the pioneers in that. What we've done is evolved on bit by bit, largely based on talking to the people that we support and finding out what they want to do. One of our projects I didn't mention is a wormery. We make worm compost. And we got in a load of horse shit and manage it quite well. And at the end of it, you get this best potting compost you're ever going to find, which growers are crying out for all over the place. For OTs, it's fantastic, because a lot of the time you have to take out the worms and move them all around and all that kind of stuff, real focused stuff, which is great if you're struggling with mental health stuff as well, because the focus is so good. You want to make it the best you can. And for people who have too much strength and don't know what to do with it, shoveling shit is a really good way of doing it in a meaningful way as well. That project evolved because one of our staff, Charlie, had this business and he just turned 70 and wanted to give it up. So we bought it off him and it evolved in. But we only did that from taking our guys up to his project to see if that's what they wanted to do, and they did. We've been doing the charcoal for years because my parents loved woods, and that was another way of adding value to the timber. The chickens we had anyway, the pigs we had anyway, and things as well. But it's really just evolving it based on our own interest. I've talked to people who have doing equine stuff, and the wormery would be a really good way of adding that on for them. So trying to encourage other people to do that too.
Thank you. Thanks, Jim, for that. We've got one question online, Aguara. Do we know why the decision was made to sell the farms off? Do we have any reasons behind that?
No, it's still very much a ongoing research. So I will try and find out as things discovered as time goes on. But no, I don't know at the minute. It just I have no idea why the decision just axes every single farm regardless of profit making or not. It just seems it doesn't seem to make economic sense to me, but there we go.
Yeah, and again, a little note to all of us, really, decisions made today may well be questioned in 100 years' time. So just be ready for that. Okay, thank you, Gwar. Thank you, Jim. Fantastic for that.
Thank you.
I'm now going to move us into breakout sessions, if that's okay. And just to be really clear, the breakout sessions, the return on investment evaluation is in here. The reading well presentation is in the ground floor of the International Pavilion, which is the cream coloured building over there. And the experience of dementia in farming communities is on the first floor over there. At the end of those, lunch will be served, and there'll be time then to look at posters and do the usual networking. So if you could make your way quite quickly to your desired group, that will be good. So we can move forward from there. Thank you. Okay, so if everybody's ready, we can move on then from that. I'm going to introduce Abraham, who is going to talk to us about a social return on investment evaluation of a university nature-based social prescribing pathway. So, Abraham, I think you're online, and if you want to put your presentation up and take us through that, that'll be great. Thank you.
Good morning, or maybe it's good. Actually, good afternoon, everyone. My name is Abraham Akinjola, and I will be presenting there's some research that I've been a part of. Let me just get my screen up now, and then we should be able to proceed.
That's great, thank you.
Okay, great. You can see my screen. All right, so yeah, this is a social return on investment evaluation of a university nature-based social prescribing service to support mental health and well-being. And this was conducted at the tail end of last year, and it was part of a wider study, but I'm just going to be focusing on this particular arm of the wider study. So this is an SRI evaluation of Wrexham University's nature-based social prescribing service. And this is basically a service that is put into place that has a number of different workshops and nature-based assets for staff and students to access, which are free to attend in most cases. So some of these workshops include pet therapy days, where you get to pet dogs and other animals to kind of help with your stress and well-being. There are candle making workshops. There's aromatherapy oil workshops where you can learn how to kind of make those and put them together. And then there are also some like physical assets as well, such as like a sensory garden, there's an outdoor gym, and then there are also some outdoor working spaces as well. So just as a brief introduction for some of you that may not be familiar, social prescribing is an umbrella term that describes a person-centered approach to connecting people to their local community assets. It encourages autonomy and agency and self-empowerment for people to recognize their own needs and strengths and to connect with their communities, and then also to ultimately be able to be responsible for their own care and how their life goes. So here you can see a brief but non-exhaustive list of some of the things that fall under the social prescribing umbrella. So you can see water-based intervention, nature-based social prescribing, financial well-being, exercise referral, housing support, and community centres. But again, this is not by any means an exhaustive list of what is available in social prescribing. So nature-based social prescribing describes groups, interventions, or services that support individuals to improve their health and well-being through contacts and spending time in natural or semi-natural environments. So as far as this is concerned, the reason why we're conducting this study is because student mental health faces many academic threats, as I'm sure you can understand for those of you that may have gone down that path at some point, or if you know somebody close to you that's currently going down that path. There's issues with stress, with acclimatization to a new environment. Maybe it might be a case of that you're neurodivergent and you need to try and figure out how to stay on top of what is going on in your studies. There are many things, and there's evidence to suggest that nature-based social prescribing provides a means to engage different populations to benefit social and community cohesion, and this can have a positive impact on people's mental health, and there are also physical benefits as well. So as I mentioned previously, this project is building upon a previous study which was commissioned by the Higher Education Funding Council for Wales, and it's part of a wider study which also includes some scoping review research, group concept mapping, and some other qualitative methods as well to really kind of dig deep into this research area and provide a lot of robust evidence. So there is a report that is available, which if anyone wants to see the overarching report, please feel free to email me. And so the reason why we conducted an SRI is because it provides a narrative on how organizations create value for key stakeholders. So, and this is by providing a ratio that states how much social value in pounds is created for every £1 of investment. So SORI enables organizations to place a monetary value on important outcomes that are otherwise monetarily intangible. So to give an example, let's say that as a result of engaging in the nature-based social prescribing program, I feel more confident. Now, it'd be very strange of me to say to you now, I feel as a result of engaging with this pathway, I feel £10 more confident, because that doesn't make any sense. In fact, it sounds very strange. So therefore, social value is what allows us to then quantify these changes in a way that actually makes sense and is supported by statistical methods and empirical data and real world research as well. So the aim of this study was to estimate the social value of the Wrexham University nature-based social prescribing service by comparing the cost to deliver the service with the monetized outcomes experienced by the students specifically. So we looked at mental health as an outcome, increased self-confidence, and then increased access to high standard green space as well. So because social prescribing intervention is very broad, it can sometimes be difficult to evaluate and also very complex as well. So SORI provides a pertinent and robust methodology that provides clear context to changes experienced by individuals engaging in a specific intervention. So the definition of social value, I alluded to it in the previous slides, but what it actually is a quantitative way to demonstrate the relative importance that people place on the changes they experience in their lives. So once again, it is quite a ridiculous example, but again, it'd be very strange for me to say, I feel £10 more confident, because again, that doesn't make any sense. Some, but not all of this value is captured in market prices. So this is why social value is important, because some of these changes, there isn't a sum that you can attach to it, whether it be by financial proxy or just because of what is currently offered in the landscape of whatever intervention we are trying to evaluate. It's important to measure social value from the perspective of those affected by an organization's work. So for example, we were looking at students as our key stakeholders, but for example, the friends of students would be beneficiaries of positive changes. Their family members would be beneficiaries, their lecturers, and even the people conducting and commissioning the pathway would also have some form of benefit, but those are third-party benefits. So it's hard to then say that this is directly the result of the intervention, which is why we look at specifically those who engaged with the service. So again, examples of social value include improved confidence or increased mental well-being. But again, there are ways in which we derive the social value as opposed to just me saying I feel £10 better. So these are important, but not often measured in the same way as a financial value. So what social value is and what it isn't. It represents the well-being uplift to an individual using money as a common metric, but it's not an actual financial return. It's not savings to the state as well when you see the ratio, and it's also not money in the pocket of participants. It just represents the value that has been generated to the individual and also to wider society as a result of engaging with something and receiving a positive change. So social return on investment and social cost and social value are part of His Majesty's Green Book. So this is central government advice and guidance on appraisal and evaluation for specific interventions in health. So we looked specifically at stated preference and also well-being valuation. So stated preference in terms of willingness to pay, to be able to determine the value that these students place on engaging with the service. And then well-being valuation is to actually be able to quantify the outcome measures of improved confidence, having access to green space, and also improve mental well-being. So as far as the methodology is concerned, we used an explanatory sequential design. So those are a lot of, kind of flowery words, shall we say. But what that essentially means is that the questionnaires that we used would then be informed by interviews that we would conduct on the back end. So that way we can see some form of causality, and there's also contextualization of the figures that we we were able to collect. So there you can see with that arrow, we had an opportunity sample, which basically means that those that were present and available were part of the people we included in this data collection. And as for the quantitative methods, we used a one-time questionnaire at the end of the intervention. So we asked them questions about their demographic data, and then to measure the actual outcomes of improved mental health, increased self-confidence, and then access to green space, we used the short Warwick-Edinburgh mental wellbeing scale, the general self-efficacy scale, and then a time and nature question as well. We use contingent valuation, which is what I mentioned previously, which was the way in which we can elicit the value that the students place on engaging with a specific service or intervention. And then for qualitative methods, we did attempt to conduct semi-structured interviews. However, because sometimes students can be a difficult population to engage with, and we didn't have the foresight to plan as well as we wanted to the end of the data collection, it coincided with the Christmas holidays and then subsequently the January exam season. So naturally, students didn't have as much time to prioritize having an interview with us. So that's one methodological limitation of this study, but it's something that we hope to kind of mitigate against in the future. So as I mentioned, this study took place in Wrexham in North Wales, and it was conducted between September and December 2023, which was semester 1. And as far as the SRI approach is concerned, there are 6 key steps that we followed. So first, you identify your stakeholders, which in this case were the students. Then we develop a theory of change. So this is the way you say that we go from the input, which is the service, to outputs, which are the costs, outputs, which is the service, so the away days, the pet therapy, and all these other things. Then we go to the outcomes, and then finally the long-term impact. So how this changes their life for whatever amount of time they expect or we expect to see. So as I mentioned, number 3, we calculate the inputs. Then we'd evidence and value the outcomes. So it's not enough to just collect these outcomes. We also have to make sure that we adjust them relative to what else is going on in people's lives. So we adjust for dead weight, attribution, and then also displacement as well. So next, once you've done that, you have to establish the impact. And then finally, you'll calculate the SOR ratio. So as I mentioned, this is a journey from going from the inputs, which are the costs, then you go to the activities, the outputs, the outcomes, and then finally the long-term impact. So as I mentioned previously, with identifying stakeholders, we look specifically at the students and nobody else. So as far as key demographic information is concerned, we had 69 return questionnaires, and there was an average age of 28 years old. There was a heavier skew towards female participants, and 62% of them were international students, which I think is quite important to take into account. 58% of the students cited stress as their main reason for signing up. And as we mentioned, the primary stakeholders were those who directly experienced the service. So we had a 76% response rate for our questionnaires. So for the logic model, once again, this is the journey from inputs to outputs, outputs to outcomes, and then the expected impact we saw as far as long-term benefits were improved mental well-being, improved confidence, and increased access to high standard green space. So for calculating the inputs, what we had to do was take into account all of the potential costs that are a part of having such a service. So you can see the cost of the student navigators, some admin supports, and other staffing costs. Then there are developments to capital infrastructure. So I mentioned there was a sensory garden, there are the outdoor gym facilities, and then also the outdoor pods. So naturally this comes with a cost as well. Then also there are transportation costs for any off-site activities. There's translation, because of course Wrexham, being in Wales, it has to be bilingual, has to be promoted and shared in Welsh and English. Then also there are Wrexham University overhead costs, and then non-staff intervention costs, and then project costs as well. So we saw per person, this costs roughly 1,196 per student per semester based on the 91 students that we saw. So as far as evidencing and valuing the outcomes, for mental well-being, as I mentioned, we use SWEM-webs. For self-efficacy, which is known as confidence, we use the self-efficacy scale. And then for high standard green space, we use time spent in nature. So as far as well-being valuation is concerned, in order to derive this for mental well-being, we use the SWEM-webs. Now, it's a 7-point questionnaire, and the responses are coded from 1 to 5. If you score 1 on the question, it means that that's the lowest possible mental health you could have for that specific scenario, and then 5 is the highest. So naturally, if you score 1 for all of the 7 questions, the score you get is 7, and that's the lowest score you can have. And if you score 5 for everything, then the highest score you can have is 35. And as a result, Symmetrica, in partnership with the housing, I believe it's the Housing Authority Charitable Trust, they basically were able to derive social values that align with these SWEM-web questionnaire scores. So you can see, for example, having poor mental health, which is cited as between having a score of between 7 and 14 out of 35, has £0 of social value. And if you have, optimal social health, as far as they're concerned, having a score of 35 out of 35, then there's a social value of £26,793. So in terms of how these are derived, it's basically a case of national data sets were taken as a result of looking at changes in people's lives. So at the top, you can see they look at the community investment outcomes model, and the outcomes are quantified, and that is known as having an impact on your well-being. And then on the bottom side, the changes to income as a result of lottery wins is what they based the other side of the impact on your well-being. And that's how we were able to derive, that's how they were able to derive the social values for the specific outcomes, whether it be mental health, whether it be increased confidence, whether it be better physical health. There's about a list of 88 values that the social value bank uses or has available to quantify these things. So once again, in terms of how it's derived, the data sets which are used are the British Household Panel Survey, Understanding Society, the Crime Survey for Wales and England, and then the Taking Part Survey as well. And again, these provide a large number of data sets which allow the social values to be derived. So that's a little bit of background on that. So as far as actually using it and applying it within this research, using the mental health social value calculator, what we have to do is start with our baseline scores, which you can see here. So in this column, we have some of the baseline scores that the students responded with, then their corresponding social value. Then next after that, we have the follow-up scores. So the change that they saw within that time frame of the semester, the corresponding social values for those. And then we take the estimated change. So the difference between this column here and the baseline social value. And then after that, we adjust for dead weight. So dead weight is accounted for in the mental health social value calculator as 27% of the change that was seen as far as social value is concerned. 27% of that would have taken place irrespective of whether they participated in this intervention, because other things in their life can cause positive change. So it would be very what's the word I'm looking for? It would be very it wouldn't be methodologically, and also and as far as integrity as far as research and integrity goes, it wouldn't be good to attribute all of this positive change just to this intervention, which is why dead weight must be accounted for. So once this was all taken into consideration, as you can see by the arrow at the bottom, the total social value per student was £2,183 of social value as it pertains to mental health, or improvements in mental health, shall I say. Now, for the other outcome measures that I mentioned, there's a different calculator that is used. So here you can see some of the other outcomes that are available. So there's high confidence, relief from depression, good overall health, smoking cessation, but naturally we just looked at high confidence and then access to green space. So as far as establishing the impact, this table looks a bit convoluted, but it's quite easy to follow. Essentially, for us to be able to attribute a positive social value to a student, there has to be some significant change. So we said for the self-efficacy scale, we needed to see us an increase of 5 points or more. Now, bearing in mind the scale is out of 40, and the lowest score you can have is 10, because once again, the responses are coded 1 to 4, and there are 10 questions. So we said we needed to see 5 points or more, which is just over a 10% change in order for them to get that social value. Similarly, for the time spent in nature, we said we needed to see an increase in time spent in nature by over an hour every single week in order to give this or attribute this positive change. So then here you can see in this table, we were able to account for dead weight for attribution and displacement. So dead weight, as I mentioned, is what would have taken place anyway. Attribution is what percentage can we say was directly attributable to the intervention. So how much of this change is a direct result of this intervention? And then finally, displacement is taking into account what they would have had to give up in order to take part in this intervention. So as far as their time is concerned, instead of going to the social prescribing service, ordinarily they might go to the gym, they might go on walks. So these are things they had to give up in order to participate. So this has to be taken into account. So here we just have the stated preference responses. So as we said, 58% of students cited stress as their reason for signing up, and they had an average income of £125 a week, and they valued each session at £7 based on what they could afford as students. So as far as calculating the SORI ratio is concerned, we take the total social value of student outcomes and we divide it by the cost to run the service. So here we can see that there's a positive social value generated by this intervention, and the social values range from £1.45 to £2.38 for every £1 invested in this service. So just to wrap up, because I understand that I don't have much time left, these 3 outcome measures were piloted and co-produced with the students and also the research team as well, to make sure that we chose the most appropriate outcome measures. And one thing which we thought was worth looking at, because 62% of these students were international students, it would have been good to look at their reductions in loneliness and social connectedness as well. But that's something that we could look at in a future study. Staff outcomes are also worth looking at because they benefit from the service as well. And this pathway aligns with the Welsh model of social prescribing, which emphasizes holistic, person-centered methods. So as far as the methods are concerned, some of these SORI calculations are susceptible to bias depending on how the researcher looks at it. We lacked qualitative data, as I said, because of the timing of when the intervention ended, and there's no control group, and also the sample size is quite small as well. However, in terms of strengths, as far as strengths are concerned, this study was corroborated by other studies which have been conducted about nature-based social prescribing. This was the first study, to our knowledge, to apply the 2 methods of wellbeing valuation using the mental health calculator and then the social value calculator. It also places a monetary value on outcomes that are relevant to these students, and it allows for contextualization of student outcomes and the benefits associated with real-world research. So with that, I say, Diok and Val, thank you for your time. And if you have any questions, feel free to ask now, or otherwise, there's my email address that you can use to contact me later on. Thank you for your attention.
Thank you for that, Abraham. Thank you very much. Any questions from anyone in the room? No. Anything online? No. Okay, then thank you very much for that. And we will now move on to the lunch break, if that's okay. And I think we're back in here for 1:30 today. 1:30 for the next breakout session. Thank you. Okay, ladies and gentlemen, if we could possibly kick off, that would be really good. So just to be clear, in here, I'd rather die of cancer than make the journey. In the ground floor over in the pavilion is co-producing integrated community health and wellbeing services. And in the upstairs room is reducing nursing turnover in Hull University Health Board. So if we could make our way to where we need to be, that would be really good. Okay, so if and when we're ready. Is that Dr. Underwood again? It's causing problems. Okay, thank you, everybody. That's really good. I will now hand over to Gemma and Emma. And over to you guys. I don't know who's leading the...
Oh, thank you.
Gemma's going first.
I feel like in the afternoon slot, I should like get you up to do jumping jacks or something to energize the room, but I promise I won't do that. I'm not that mean. Thank you so much to the staff for the excellent lunch. I very much enjoyed mine. I hope you all did too. Thanks for having us on this agenda. My name's Gemma Elliott. I'm the Director for Wales for the Community Transport Association. I'll tell you a little bit more about this quote a little bit later on in the slides. But just to give you a bit of an overview of what Emma and I are going to be talking about today, we wanted to take the opportunity to talk a little bit about how health working in partnership with community-led transport providers can have a significant positive impact on patients, carers and communities, as well as the NHS in Wales. So Community Transport Association, we're a membership body. We're a charity that supports a network of other charities and community groups, organisations, social enterprises, local authorities, right the way across the country. We cover the whole of the UK, and in Wales we have more than 100 member organisations who we work alongside. As well as our members, we also work with a range of other partners from health boards, local authorities, community councils, anyone who has an interest in accessible and inclusive transport. So we've really been focusing this year on transport that leaves no one behind. And our vision as a charity, sort of leading a movement around community-led transport, is of a world where everyone in every community can access transport that meets their needs. So when we think about health, gone too far? Yeah. There we go. We, in October, hosted the second ever Community Transport Week. So some of the photos that you'll see on the slides are from events that our members held over CT Week. And I just wanted to give you a little bit of a flavour of what community transport looks like and feels like if you haven't come across it before. What unites community transport providers is a community-led response to an unmet transport need, and that varies from community to community, and especially in rural Wales, demand responsive transport models are a really, really important way of helping people to access health and care settings. In Wales, community transport providers make more than 750,000 journeys per year, and on average, more than 60% of those are to health destinations. So it's a really important part of the transport landscape, but it is something that very often is sort of unseen and unrecognised as being a vital part of how people access health and live well in their communities. In a recent event that we hosted to launch the manifesto that we put out in advance of the UK general election, we were joined by a colleague from Amnesty International who shared this quote. And it's not specific to health, but fundamentally, I think it's a really important one, that if transport doesn't exist, if transport is taken out of a system, it makes everything fundamentally more difficult. So Jen from Amnesty International talked about this in the context of their work around universal human rights, as transport being a linchpin right. So when transport gets pulled or transport disappears or transport is not available at all, it means then that it's very, very difficult for other systems that work around individuals and work around communities to function. As an example of this, Emma has been doing a piece of work over the last few months with the West Glamorgan Partnership, looking at health and social care needs for people with learning disabilities. And something that Lindsay, one of the leads of that project, said in a recent event, that at the beginning of the project, nobody had thought of transport as being part of health and social care. Very often, the only bit that is actually sort of commissioned is non-emergency patient transport services, which are delivered by the Wales Ambulance Service Trust. Some elements of that are subcontracted, and our members are some of the providers that are involved in that. But actually, there's a huge amount of access to transport that doesn't fall into that commissioned provision. This is where I sort of want to go back to the quote at the beginning, really, that we heard from a patient that's being supported by a project in Risca, in the Valleys. And the reason that my colleague Alison is here today is the project coordinator for that work. And we work with Hywel our Health Board to support a network of organisations to add capacity to help people access healthcare settings. So we've got a range of different organisations and groups that are involved in that. And one of the passengers was a lady who was going in for chemotherapy and was being supported by the non-emergency patient transport ambulance. However, because her chemotherapy was really, really challenging, she wasn't able to take anybody with her on the next bus because the person that was supporting her didn't have a clinical need, so they couldn't find a place for them on the bus. She was exhausted at the end of her treatment cycle, and the bus, because of the nature of the capacity that WAST have, was having to travel for more than 2 hours at a time, picking people up on the way into the hospital. Then you'd be all day in the hospital and then dropping everybody home. And as a result, this particular patient was just exhausted and unable to function for the rest of her week. And because of the nature of the cancer that she was living with, she was going to be having that treatment for a really long time. And she wasn't financially in a position to be able to pay for a taxi. She didn't have her own car. She didn't have any family nearby who were going to be able to get her to and from the hospital. She did have support from a carer part-time, who would have been the person that came with her on the chemotherapy appointments, but that person wasn't able to accompany her because of the next criteria. So it's not that there isn't provision there. I think it's sometimes that decisions are made that have an impact on patients and have an impact on passengers that could be looked at through a different lens. And community transport, when our member was able to offer a much, much lower cost to provide a door-to-door service to get that patient into the hospital, the volunteer who was delivering the driving also stayed with her for a number of the appointments where she was feeling really unwell, made sure that she got in after they dropped her home, helped her get a cup of tea. It was life-changing for her. And when we talk to health boards and other providers, social care settings, I think it's those kind of added value elements that sometimes if you're relying on a next bus or you're relying on a taxi, you just don't get. And it's those kind of additional elements that community transport is able to bring. But often it's something that, because it doesn't exist in the statutory guidance, I think it can be really difficult for health colleagues at any part in the system to be able to make an argument that this is something that's really valuable. Something that we've seen with our colleagues in the CTA England team, the research that they've done over the last 12 months shows that despite, again, a very similar proportion of journeys going to health destinations, only 1 in 4 of our members in England are in contact with the health board that they're supporting, and less than 1 in 10 of them receive any kind of funding, whether it's a grant or a contract or anything like that. So it is something where it feels like there's a real disconnect between health and how people access it. And what we wanted to talk about, and what I'm going to hand over to my colleague Emma to talk about a little bit more, is how we think transport can be an enabler of health and wellbeing, especially in rural communities. So Emma?
It's interesting this morning that we've heard about community-centred health care, and we believe that community-centred ways of working can be more effective than traditional services improving health and well-being, especially for those marginalised groups in society. For this reason, they are an essential way of reducing health inequalities. So localised working, looking at your community is really vital. Those that find themselves excluded from society are lacking in power and control, and that can be because of health inequalities and poverty, often have the worst health, but the least ability to access services. So adopting a more community-centred practice can help provide more appropriate and effective ways of engaging people, improving their health and well-being. So engage, talk, communicate, that's what we should all be doing really, really well. If we empower communities to look at transport, what their options are, this can change access to health, and we will see better outcomes for all the people that you are working with. Transport is often the last thing you think about. But once you don't have any and you are alone, then it becomes a really significant issue and it stops you accessing care. It's a huge barrier. By health services engaging with CTA, we know that we can create positive pathways for people to access health and wellbeing services. I heard this story yesterday, so I wanted to tell you about it. One of our CT operators was working with a young lady on the outskirts of Swansea. She was in a powered wheelchair, and that wheelchair did not fit on any taxis or the community transport bus. So that Jeff has been working with her carers, her support staff in the NHS, and last week she got a new powered wheelchair that fits on the bus. She's a young lady. Where did she want to go? Macarthur Glen. So she was taken to Macarthur Glen. She has not been out of her home for 18 months. So think about her well-being being stuck indoors. It sounds a simple thing, a trip to Macarthur Glen, but apparently there were lots and lots of smiles. Caring and supportive transport, it changes lives. What does this mean in practice? So I've got my assistant here because I'm not very good with these things. So we know that by enabling someone to attend an appointment, we ensure that they access the NHS less. So if they see their GP, they are less likely to enter A&E. We also know that if people access social and leisure activities, they also enter the NHS less. They have better physical health and better mental well-being. They just don't need the interventions that the health service give. It's interesting that social prescribing came up earlier, because we know social prescribing is happening in Wales. We know that GPs are asking people to go out, go outside, be more active, go to lunch clubs to improve their physical and mental health. But if any of you do that, do you ever ask the question, do you ever say, how are you going to get there? Or do you say, well, go out walking, we'll see you next week? And that's a really important thing. You can prescribe something, but if you don't give access to it, then that person will never, ever do it. We've got a walking group in Pembrokeshire, and one of the gentlemen was told by his GP that he could benefit from the walking group. So the local community transport, the Bloomfield bus, picks him up and off he goes walking. In a month of regular walking, he has reduced his cholesterol to a level where he has reduced his medication. So again, that simple thing of being picked up, taken for a walk, has meant he accesses the NHS less. It's really important. Without that bus, this would never have happened. Our operators keep communities moving, socialised and active, and this directly impacts the health and well-being. In Pembrokeshire, our operators do a low level of health journeys, but a high level of wellbeing journeys. It goes slightly against the percentages that we see across Wales, but we know that each of those journeys makes a difference to that person mentally and physically. So what does good health transport look like? Gemma and I could talk all day, really, about what our operators do. But we want to focus on one of our services, which is Pivot, which I'm sure some of you will have heard about. So Pivot runs in Pembrokeshire at Withybush Hospital. It's run for a number of years. It's a collaborative service funded by the Health Board with Pacto, RVS, St John's Ambulance, Care and Repair and Volunteering Matters. It's funded by the NHS now and is there to reduce bed blocking. So it's for those people that don't have the means to get home if they've been in hospital. As you can see from this slide, and this is on statistics taken from some Pivot that we had from September last year to October this year. So if every one of the journeys home from hospital that Pivot did within that time saved just one bed day, then that calculates at £145,755 saved by the Health Board. This is a massive amount of money. And that's just one hospital, that's just one service. That doesn't take into account all the other health journeys that are done by our operators. A Pivot volunteer ensures a person is safe and settled at home, so they may stop on the way home to get bread, milk and soup to enable them to be safe for 24 hours. And they then can refer onward into the other partners. So what can be seen as an insignificant intervention, a trip home, insignificant, getting in a car and going home, actually starts a chain of events and support that enables that person to probably not be readmitted into hospital as quickly, to less likely need emergency care support because they will have volunteering matters go in for 6 weeks. They might have care and repair go in to put adaptations to their home. So one volunteer, one car creates this journey for this person that supports them for as long as they need. And that's the reality. If community transport can support the health service in enabling them to treat people who are acutely ill, and community transport can support those to actually uplift their mental and physical health within their communities. And this is really important.
Thanks, Emma. So it's been quite interesting sort of listening to some of the talks today. I was really kind of lovely hearing Jim this morning talking about the care farming kind of experience. Transport is an enabler for that kind of activity right the way across Wales, and often it is organisations where their primary activity is not transport. Transport is just there to facilitate that activity. I also went to the session with the reading agency, and it was really interesting to hear Amy and Gemma at the reading agency talking about access to libraries being a blocker that has a contributing effect to people's health and well-being. And that's something we hear all the time, you know, similar to the quote that's on the opening slide. We hear negatives. We hear about the number of times people are prevented from accessing their community, from connecting with the people and the places that they love. But what we hear, you know, what we're very privileged to hear at the CTA are the stories where the opposite is happening, where community-led transport providers are enabling that health and well-being to happen, whether it's directly by accessing health settings, taking you for your COVID and flu vaccination when you need it, and not having to rely on a family member or a friend or having to pay a really expensive taxi fare, through to regular community buses that enable you to shop independently or to connect with your community. So what we wanted to focus on just as we bring this session to a close is thinking about some of the examples of collaboration that we're already seeing and some of the ways in which colleagues across health and social care might be able to get involved in this a bit more in the future. So we've already got some examples. I mentioned in Iron Bevan the work that we do on the Transport to Health project there. It's not a perfect system, I would say. It's something that we're still evolving, but it's fantastic to see the Health Board directly investing funds in creating more equitable opportunities for people. We've also got a project that's in the very early stages with Cardiff and the Vale Health Board at the moment, where a GP surgery is being moved. And rather than the example that I mentioned earlier on in the presentation, the health board are proactively seeking to engage with the community about what that move is going to mean and how are people going to be affected and how community-led transport might be part of a solution to those effects. So that's a fantastic proactive example where a health board is really thinking about how they can work in partnership and collaborate with the community in order to make sure that people are still able to live healthy and well lives. So if there are things like that that you're working on or you can see coming in the future, we'd love to have a conversation with you about it and connect you with community-led transport providers or explore potential new community-led transport in your area, because that's something that we do on a regular basis. Data is another really important thing. We're a very small team and we're not research experts. So we try and work in partnership with people who are to get the data that we need to make this case really strongly. So over the last 18 months or so, we've been working with the Transport and Health Integrated Network led by Aberystwyth University. One of the projects that they're working on at the moment is trying to provide evidence to the Welsh Government of how many appointments are missed as a result of a lack of access to transport. And it's really difficult to pin that data down. So if you're in a health board where you might be able to help us to get access to some of that data, we'd love to have a conversation with you about it, because that would really help us in making the argument that Welsh Government needs to invest more in this, that less people would miss appointments if they had better equitable access. And thinking about equity, I suppose that link to social prescribing, we know that when it comes to activities in the community, warm hubs, which are going to become a really important thing again over the winter pressures period, we would love the opportunity to work with more partners in health and social care to explore how people can have more equitable access to the provision that's already there. We know the NHS invests a huge amount of time and energy and money in creating opportunities for people to be healthy and well. And we also know that a lot of people, because of poverty and because of rurality, are not able to access those interventions. So if there's an opportunity to work with you on exploring how we might be able to link you up with your nearest community transport provider so that more people can access that warm hub, so that more people can get to the walking club or the local, I really wanted to say knitters and nutters because that's what my gran calls it, knitters and natterers. Those kinds of interventions that we know are really, really valuable for helping people to be confident and independent in their community. We'd love to have those conversations, and we're always open to exploring what collaboration could look like and how we can open up that equitable kind of access. One example, which unfortunately COVID sort of did in, but I thought it's worth mentioning here, about 5 years ago, we worked with GP surgery in Conwy, and they'd identified that they were experiencing a huge number of did not attends. They had really, really high levels of patients not coming to their appointments. And doing their own research, they identified that transport was the primary barrier that was preventing people from coming to the surgery. So the lead GP, was a GP who was kind of pushing forward with it, worked with us to create a new project, and they cited a car at the GP surgery and worked with us to create a network of volunteers to drive that car to go and collect patients, bring them in for their appointment and take them home again, and opened up the access to the car then to the community to use for other reasons. Now, unfortunately, because of COVID, it really did a number on an awful lot of our schemes, and a lot of our volunteers, unfortunately, left community transport at that time. But it was a really exciting example of something that was very much led with a health lens, looking at how we could ensure more people were able to access their appointments, but working in partnership with a network of community members. And it had a huge impact in the time that it was running. And we'd love to explore more of those opportunities with you. I thought I'd finish, obviously bringing this quote back up on the screen, mainly because our email addresses are down on the bottom of it. So, and I've got my card as well. If you want to have a chat with me afterwards, I'd be really happy to. We'd love to chat more. I thought I would share some examples of quotes that we've had from passengers who do have access to the support that they need by community-led transport. And these are all real quotes that we've had from passengers using community transport at the moment. Thank you so much. I would not be able to attend my appointment without the community transport. They care about me and they talk to me. I have my independence through them. My family don't need to be involved in my treatment yet, and that makes such a difference. They were so understanding of how I was feeling, and good transport helps us to live better lives. So thanks so much. Enjoy the rest of the afternoon.
Thank you for that. Again, something that really does play into what we're talking about and what we're trying to do in terms of service provision, in terms of trying to work with communities, etc., and often overlooked really in terms of where we're at. So any questions in the room from anyone before I move to any online questions? No? Have we got anything online? Nothing online. So thank you both for that. Really good. Thank you very much. So our next session will start at 2:15, I think. So we've got a little break now. So please network as appropriate. Okay. My conscience is telling me that it's time to start again. So we'll start again in terms of moving forward. So Helen, where are you? Helen, there you are. Right. Hiya. Thank you, everybody. So is everybody in the right places? We're not expecting anybody to move. Good. Excellent. Okay. So Helen, over to you, really. Thank you.
So this is the forward. Yeah, thank you. Oh, great. My time. Cynhadledd, there we go. Start again. Good afternoon, everyone. My name's Helen Hedworth, and I am the Research and Evaluation Coordinator at Coedlail Smallwoods. We're a charity running social forestry programmes across Wales, reconnecting people with woodlands for their health and well-being and to promote sustainable woodland management. I'm really pleased to be here today, so thank you for having me. There's been some really inspiring talks so far, and it's really interesting to see how everybody's interconnected and doing different sorts of work. So I'm really pleased to be here today to talk to you about the feasibility study we completed earlier this year with our partner, Local Development Trust Ecodyfi, now known as Biosphere Dyfi Biosphere, in the catchment of Cynhadledd Community Hospital and Wellbeing Centre. Should put it this way, shouldn't I? So just a bit of background to start off with, for a bit of context of the work. There's now a great body of evidence demonstrating that nature is good for us, improving mental health, increasing lifespan and reducing chronic disease. Nature is in fact so potent that even a suggestion of it, for example, through photographs, videos, views, scents and sounds, can help to reduce stress, anxiety and boost the immune system. A 10-year study in Wales showed that there was an association between exposure to green spaces and reduced risk of future common mental health disorders, especially for deprived communities. And yet, despite this, in Wales, many people do not go out to reap these benefits. The availability of organised outdoor health activities can vary depending on the area, and there's often no such network of activity providers. This year, there was a study that came out on the economic value of the benefits of nature-based physical activity, and it was estimated that of 22 million adults who visited natural environments in England at least weekly, physical activity on these visits prevented 12,763 cases of non-communicable disease, and that was estimated to have saved £108.7 million in annual societal costs. Last year, we saw Welsh Government's National Framework for Social Prescribing, which includes a strand green social prescribing, and this all falls within the context of the climate and biodiversity crises, Welsh Government's Healthier Wales, and of course, the Wellbeing of Future Generations Act. So the policy landscape is increasingly pointing towards a more joined up approach across the sectors, focusing on sustainability and preventative approaches, including green social prescribing. And the need for this feasibility study emerged at the end of a 3-year study that we led, Troeddiach, Outdoor Health Network, providing outdoor activities on prescription, with one of the key recommendations being to engage further with one healthcare location to build an exemplar site. So feedback from hospital staff and from the Patients Forum suggested a need for and a willingness for taking this forward from the Brotherby Community Hospital. So the main question really is, how best do we understand if the newly renovated Brotherby Community Hospital, set in the UNESCO Dyfi Biosphere in Mid Wales, could complement hospital-based healthcare with outdoor health and wellbeing opportunities, and create a model of how this could work in practice for other sites in Powys and across Wales. So the outline of the study, it ran from September last year to April, and was funded by UK government and powered by Levelling Up through the Shared Prosperity Fund, managed by Powys County Council. The feasibility of a coordinated outdoor health offer from the community hospital was explored in its catchment population of approaching 7,000 people based in Powys, but also stretching into Ceredigion and Gwynedd. And the hospital received funding for a redevelopment, reopening last year to offer primary care, community services and social care under one roof. Based in the Dyfi Biosphere, the area is known for its high biodiversity and natural spaces. And the project was guided and informed by a steering group of representatives, which I've listed at the end of the presentation. As I said before, it follows on from the Troeddiach project. And it contained engagement events and also community and staff surveys and interviews with staff at the hospital. And it culminated in a report with specific, measurable, achievable, relevant and time-bound recommendations. So our objectives were to engage a wide range of stakeholders to steer and inform the study, to consult with the community on their needs and their aspirations relating to their health and the outdoors and the new community hospital, to explore if outdoor provision could be a part of an integrated approach to healthcare at the community hospital, and propose a vision of what this integrated approach would look like, with a series of recommendations for the next 5 years of work. This is how we did it. We did some literature review, we did surveys with the community and with staff at the hospital. We ran a series of engagement events. We had interviews with the heads of departments at the hospital. We led focus groups. We had site visits, and then we had a series of focus meetings, did some desk research, and looked at the feasibility and cost analysis. In all, we had over 600 people consulted, and the response to our surveys were 400 adults and 45 children and young people. So the results, they were gathered into a series of different perspectives. We had the hospital site and the wider area, and we looked at the facilities there currently on offer, and we thought about how they could be used and improved. We considered results of the community surveys. We thought about the staff needs from the staff surveys and interviews, as well as the staff's thoughts on patients. And we also considered the perspectives of activity leaders in the area. And when we looked at all of these different perspectives, there were some themes that emerged. The first theme was about well-being needs. Mental health was the top of the self-reported conditions in the community survey. Almost half the respondents to the survey reported depression and/or anxiety, and more than a third had mobility issues. Many also had other conditions such as mobility and joint pain, arthritis, osteoporosis, high blood pressure, asthma, and sight and hearing issues. The mental health unit at the community hospital was experiencing challenges in dealing with an increase in population level distress. And staff at the community hospital reported heavy workloads they said that they would benefit from support with managing their own stress and anxiety and improving the connectivity in the team. All of the staff interviewed felt that more support for staff wellbeing would be welcome. The next theme was prescribing nature and the outdoors. Community adults, young people, and the hospital staff felt that the outdoors helps their health and wellbeing. And everyone who took part in the community survey was interested in taking part in outdoor activities. Staff thought that nature-based and other outdoor activities would be beneficial for patients at the community hospital. And there was strong support for outdoor and nature-based activities to be available on prescription, judging by the community survey. Clinical staff also said that they would like to be able to prescribe outdoor activities alongside clinical prescriptions. The community hospital staff had an interest in and enthusiasm to engage more with the outdoors for their own well-being. And they said that the main barriers for this was the lack of time and not having a private area outside in the hospital grounds. The next theme was activities. The most popular outdoor activities that adults responding to the survey would like to take part in were woodland skills, outdoor cooking and foraging, outdoor arts and crafts, accessible walking and movement, conservation, and nature mindfulness or quiet time outdoors. Children and young people were most keen to spend time with animals, develop woodland skills, do outdoor cooking and foraging, wild swimming and cycling. And the biggest barriers identified in the survey to taking part in outdoor activities for adults were a lack of time, not knowing what's available or appropriate for them, bad weather and limited public transport, something we've already heard about today, but as well as that, nervousness to meet new people. For children and young people, it was bad weather, a lack of their own transport, and limited public transport options that were the barriers. There was therefore a preference for local activities and a willingness to travel up to 10 miles to take part in outdoor activities. There was also a preference for activities at the weekend, but almost half of the respondents to the survey said that they would attend during the week. And support for transport is something that should be explored for future projects. 90% of community respondents said that they would be willing to pay for outdoor activities, depending on what was being offered, but also potentially with a pay what you can approach. And the community also said that they would like a central point of information to know what outdoor activities were available. The next theme was network of outdoor activity providers. There's already a range of skilled and experienced outdoor activity providers in the area. And those providers highlighted that some of the challenges they experience are working part-time, often on a self-employed basis. The work can be irregular and is funding dependent, and there's currently a lack of funded opportunities in the area. So they'd like to have stronger links with the healthcare sector and to be able to meet the needs of patients in the community. Activity leaders would also like to be part of a network that provides support, collaboration opportunities, access to funding, and that ensures a minimum standard of delivery is upheld. There's also an interest for running sessions at the hospital from these people. The next theme is the hospital site, gardens and walks. And there was strong support for a garden for patients staying on the ward. And we identified some appropriate sites in the grounds of the hospital. There was also some interest in having a walking route around the grounds, but we felt that might be quite difficult to put in place. However, an alternative would be to develop the central green spaces and add interpretation signage and seating so that it's a pleasant area to walk around and spend some time in. Improvements supported by the community and staff surveys included more seating, more trees and more flowers. There was interest from activity providers in supporting the development of this garden and in running sessions there for patients. The staff would appreciate having a relaxing and private outdoor area, and they could therefore take some time on their breaks to relax and socialise. And both community and staff would like there to be a notice board of local walks. The next theme was volunteering, and more than half of respondents expressed a potential interest in volunteering. So 19% of adults said they would definitely be interested, and 40% said that they may be interested. And we felt like this was a really high level of interest, which was really promising. The site analysis and interviews identified a need for volunteer support to help maintain and develop the green spaces around the hospital. And there could also be opportunities for volunteers to get involved in activity groups, walking groups, and developing and running a patient garden on the grounds of the hospital. And the final theme that emerged was linking healthcare with outdoor health and wellbeing. So outpatients can currently be referred by healthcare staff to the National Exercise Referral Scheme, NERS, and the Community Connector for Brotherly, PAVO. Interviews with both of those services highlighted the need for more activities to be able to signpost people to. There's a need for a joined up and connected approach to referrals for outdoor health, working in synergy with the processes for engagement by healthcare staff and the local community with the community connector for Brotherly. Since the Troy IAH programme finished, there's been a gap in outdoor activities for health and wellbeing in the area. But any interventions also need to be proportionate and implemented sensitively, because the challenges in healthcare capacity and budgets came up many times in different interviews that were held. And so if there are to be opportunities for staff and patients, it mustn't be at the expense of other critical services. So it's key to fit in with and complement what's in place and to work towards bringing in additional resources to the system in order to implement this. So we then moved on to creating a vision. We wanted to think about what this might look like, something for us to think about and to guide us. And we came up with this, which I realise in the room is now actually quite small, but people who are logged in online will be able to read that. So I'll just give you a few moments to have a look at that if you're able to. Thanks for the thumbs up. Okay, so in order to enact this vision, we came up with a set of 10 key recommendations. Number one was to establish an outdoor health development group to oversee the studies, follow-up, and the delivery of its recommendations. Number two was that the outdoor health development group would consider the creation of a new role, which we refer to in the report as the outdoor health coordinator. This role would address the need for enhanced staff capacity so that integrated outdoor health services could be enabled and there could be effective communication between all the stakeholders. The third recommendation was that the outdoor health development group would facilitate and address the financial implications of recommendations. So that would be aiming to create more capacity and sustainability for outdoor health alongside clinical care. And partner organisations would fundraise, develop collaborations, and implement the recommendations. Stakeholder organisations could explore creating a sustainable investment portfolio to ensure that the programme could be continued. And the willingness of the community that we discovered through the surveys was helpful because it shows that there could be some supplementary funding from them being willing to pay for some activities. The fourth recommendation was to establish a sustainable and targeted programme of outdoor health and wellbeing activities, including formal and informal programmes and taster days that meet the needs of the community. ensuring provision is continued and it's accessible. Connecting with other outdoor sites across the Dyfi biosphere for wellbeing and volunteering opportunities, including using the 2 woodland hub sites. Number 5 is to establish a volunteering programme for community members interested in maintaining and enhancing green spaces in and around the community hospital. Number 6 was to introduce an outdoor wellbeing programme for staff at the community hospital that complements the current Powys Teaching Health Board staff wellbeing offer. Number 7 was to establish and support an activity leader network in the Dyfi Valley to ensure consistent delivery of high quality outdoor health and wellbeing programmes. This network would collaborate with the hospital, provide ongoing training and professional development, and ensure adherence to minimum standards. Number 8 was to facilitate effective communication and disseminate the information on outdoor health opportunities via a central communication platform, like a website or a hospital notice board, social media, or probably a combination of all 3. And that would be a resource for community members, healthcare providers, and activity providers. Number 9 was to establish an integrated registration and referral pathway that caters to both the formal referral process, but also self-referrals. The pathway would streamline the process for healthcare providers, patients, and community members to make it more efficient and effective and to engage with the outdoor health programmes. It would have to work in synergy with the existing community connector services and the other services hosted by Powys Association of Voluntary Organisations. And number 10 would be to revitalise the outdoor spaces at the community hospital, enhancing biodiversity and putting into practice the proven wellbeing benefits of the outdoors and nature for patients, staff and visitors. Community and staff would like a safe, accessible, dementia-friendly patient garden, private patios for palliative care rooms, a private outdoor space for staff, amenity space for visitors, and engaging written and artistic interpretation linked to outdoor health and the hub ethos of the hospital. So, nice little photo there. And then just a final thought from me is about what we've been doing since then. So we had the steering group became the development group with all the members committing to delivering the study recommendations going forwards, and they now meet bi-monthly. We secured 2 small grants from CAVO and PAVO, the Association of Voluntary Organisations in Ceredigion and Powys, which are both counties that cover the hospital catchment, to fund small projects taking forward specific recommendations. The PAVO fund provides training for volunteers leading health walks in nature. And the CAVO fund is an accredited wellbeing and nature training for Cami Malign daycare centre staff, so that they can upskill in delivery of wellbeing and nature sessions for their young people or those registered as disabled. We also carried out further community consultation over the summer so that we could dig down further into the interest in the volunteering for outdoor health and also the types of activities that people wanted. We had focus group discussions to do this. And then finally, we had a big lottery people and places bid created by us at Coislail Smallwoods with the development group and with our 2 key community partners, the Biosphere, Dyfi Biosphere, and Tridani, a community transport initiative. This will take forward the recommendations from the study over the next 3 years, and we have other bids in the pipeline. So I would like to say a big diolch yn fawr iawn to our steering group who are listed here. Thank you so much for your input. It was invaluable in guiding the study. I've also got a references slide in case anybody wants to have a look afterwards. And if you would like more information, I've raced through that. We've got lots of data in the report. You can find out a bit more about some of the questions that were asked on surveys and some of the thinking behind it in a full report or a summary on our website. Thank you very much. Diolch yn fawr.
Thank you, Helen. Just before you leave us, don't rush off. Just in case there are any questions in the room. Any questions? And any questions online? There's nothing online. So thank you for that, Helen. And again, a really good look into how things can be set up and how things can work in various settings. So an opportunity there to talk to Helen maybe afterwards to kind of work up further plans. Okay, I am now on a break again, I think, until 3, because I can't stop till 3. Apologies for that. We're going to wait for the other groups to finish as well. So we will recommence at 3 o'clock. Thank you. Okay, thank you, everybody. We will retake our seats, if that's okay. I'll just take a moment for the return of the TQ. There we go, heating off. So we can now hear each other speak. And I'll now then ask Yuping Yu to join us. I think is online. Is that I am online? Right. Okay. So
yeah,
we can. Thank you. So we can make a start. Over to you. Thank you.
Yeah. Thank you. Hello, good afternoon, everyone. My name is Yuping Yu. In this presentation, I'm going to talk about the development and the preliminary validation of the South Wales social well-being scale. According to the WHO, health is a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. So this definition shows the holistic account of health, that including 3 key features: physical, mental, and social well-being. There are so many definitions of well-being, but there is no consensus. In general, well-being refers to what helps lives go better for people, involves mental and emotional states, social environments, and ability to access to and enjoy social and economic resources, such as health, education, employment, housing, income, community assets, and inclusive and empowering social and relational networks. So we know both mental and social well-being are distinct and important for health. A systematic and multidimensional measures of well-being is required to gain a richer and more holistic account of well-being. The Warwick-Edinburgh mental well-being scale is most commonly used to assess well-being. It focuses on the subjective, internal, emotional, and mental states, but it does not uncover the social dynamics of well-being. To address this issue, we proposed to simultaneously assess well-being by combining the Warwick-Edinburgh mental well-being scale with the new measurement tool to provide a more overall picture of a person's well-being. So a group concept mapping study was carried out first in the summer of 2020 to explore the people's perspectives on what makes up their social world. Participants were a group concept mapping is a consensus participatory mixed methods approach. The participants were recruited from academics, social prescribing practitioners, health and social care professionals, and service users, as well as members of the public. 96 participants were recruited. So they were aged between 19 to 90. Most of the participants were from Wales, and some from England and outside of the UK. The data collection involved 3 activities. First, brainstorming. Participants were responded to a focus prompt. When I think of the things that have made up my social world over the last year, I include. The participants completed this sentence by adding a few words or phrase. And the second activity is sorting. Participants sorted statements generated from brainstorming into piles or groups based on perceived similarity, and assigned each pile label. And the last activity is rating. Participants rated each of the statements on 3 scales for importance, access, and enjoyment. The data collection data analysis involved 4 steps. First, descriptive statistics were used to describe demographic data. Then a similarity metric was generated to show how frequently the statements were sorted together by participants. Then multi-dimensional scaling analysis were carried out to produce a pointer map. Lastly, hierarchical cluster analysis were carried out to create cluster maps, cluster rating maps, pattern match reports, and goes-on reports. So the bottom is a reference to a publication derived from this phase of the study. Then the group concept mapping, the data collection, brainstorming stage generated 125 statements. So these statements were sorted and rated by participants. So the concept map of social well-being that include 6 clusters or themes were chosen to, based on how the data were sorted by participants, the discussion among the team members, and the consultation with the advisory group. So, cluster 1, everyday life, activities and pastimes, including 29 items. Cluster 2, family and friends, including 25 items. Cluster 3, connecting with others and supporting needs, including 22 items. Cluster 4, community involvement, including 16 items. Cluster 5, engaging with and reflecting on the wider world, including 21 items. Cluster 6, self-worth and security, including 12 items. So the initial item pool for our social well-being scale. So the items should comprise of statements from each of the 6 clusters to reflect the cluster map, as shown on the right. 4 statements from each cluster that participants rated of highest importance were selected to form the initial item pool. So this is the initial item pool, including 24 items. The left column is the cluster number, the mid is the statements, and the right is the importance rating. So the team reviewed each of the 24 items. Items that had similar sentiments were merged. For example, the top 2 items, living in a safe home environment and living in a healthy home environment, were combined into living in a safe and healthy home environment. So statements that do not focus on the social world were removed, such as item 58, mental health, as it reflects to the mental health rather than a person's social world. So by doing so, the 14 items remained to form the South Wales Social Wellbeing Scale. So these are the 14 items remained. So the items were scored on a 5-point Likert scale from 1, none of the time, 2, really, 3, some of the time, 4, often, to 5, all of the time. So the sum of the scores ranges from 14, the minimum is 14, to the maximum 70. So this is the paper version or the word version of the scale. The left is the column is the 14 items, and the remaining columns is the scores for the rating. So after we created the scale, so we did the preliminary validation. That's the phase 2. So I'm going to talk about the participants involved in this phase and the measures used for validation, and the 3 types of testing we conducted to demonstrate the to validate the scale, including validity, reliability, and variability. So the bottom is the information of the paper we have just published to report in the development and the preliminary validation of this scale. It's an open access paper, so if you're interested, you can download a copy online. So the participants and the recruitment. The data collection was carried out between November and December 2021. The convenience sample was used. We recruited students and staff in health and social care disciplines in the University of South Wales. The data collection was hosted online on the online service platform. A link to the study website was sent to eligible participants. 103 valid responses were received and included in the validation analysis. The 3 measures were used for validation. The first is our newly developed scale, so South Wales Social Wellbeing Scale, including 14 items rated on 5-point Likert scale. The total scores ranges between 14 and 70. The second scale is the Warwick-Edinburgh Mental Wellbeing Scale. It also contains 14 items rated on 5-point Likert scale. The sum of the scores ranges between 14 and 70. Then the last scale is the 4 measures of personal well-being scale, ONS4, developed by Office for National Statistics. It includes 4 questions to measure aspects of life, including life satisfaction, worthwhile, happiness, and anxiety. The questions are scored on a scale of 0 to 10. Then the validation testing. So validity is regarding accuracy, referring to the extent a scale can measure what it's supposed to measure. So in this study, we conducted a constructive validity testing. The validity was established by exploratory factor analysis and convergent validity. So I'm going to look at these 2 tests. So the exploratory factor analysis was carried out first to produce independent factors associated with the 14 items. So a 3-factor model was found the best solution, providing a reasonably good fit that could be interpreted easily. So these are factor 1, safe and inclusive interaction with others, explained by 6 items. Factor 2, learning, helping, and feeling useful, explained by 4 items. Then factor 3, security, worthwhile, activity, family, and friends, explained by 4 items. So this is a visual presentation of a suggested 3-factor model, also called latent structure. As you can see, there are 3 factors, and they are explained by different items. So it's the convergent validity. So first, we examined the sum scores of our newly developed scale and the sum scores of the Warwick-Edinburgh mental well-being scale. So the correlation coefficients between the sum scores of the 2 scales were moderate at 0.67. So the regression of the sum scores was significant. Then the second, we compared, we did the pairwise correlation between our newly developed scale and ONS4. So the correlation were not strong, were weak, range between minus 0.12 to 0.47. Then the reliability testing. Reliability refers to consistency, referring to a scale that can measure a concept in a reproducible manner. So in this study, we demonstrated internal consistency to demonstrate reliability. We did 3 different types of tests. First, Krobach's alpha. This was a test to test how closely the set of the items were related as a group. The Krobach's alpha coefficient was 0.85 for the whole scale and ranging between 0.83 to 0.86 for individual items. Then the second test is item total correlation. So this is to assess whether an individual item on the scale is created with the total score of the scale without that item. So item total correlation coefficients ranged between 0.08 to 0.65. Then the last test is the split half technique used to compare whether scores on two randomly split halves of the items were related. The correlation, if split half correlation coefficient was not 0.78. So we conduct a pairwise t-test to compare the two split halves, and they are significantly correlated. Then this is called the variability test to check the floor and the ceiling effects. So with regard to the sum scores, so less than 15% of the respondents had the possible lowest score of 14 or the possible highest sum scores of 70. So this indicates the absence of floor or ceiling effects. So with regard to the 14 individual items, the items scoring with the lowest possible score of 1 did not exceed the 15% cutoff. This indicated absence of floor effect. But 12 items, except item 5 and item 6, had a ceiling effect. So this means more than 15% of the respondents scored the highest possible score of 5 for these items. So this affects the ability of the scale to capture the variation in our data, make it very difficult to differentiate between respondents scoring the highest possible extremes of the scale. So based on our preliminary testing, the South Wales Social Wellbeing Scale has satisfactory psychometrical properties as demonstrated by good validity, reliability, and reasonable variability. Future research is still needed to confirm its psychometrical property among different populations, use a larger representative sample, and how it can be used along the Oracle Edinburgh mental well-being scale to capture what we regarded as a thoroughly holistic understanding of the well-being. Thank you.
Thank you for that. And just before I get to online, is there any questions in the room before I? No, anything online? No. No. Okay. Thank you again for that. Interesting and important, really, to brings us back to evidence-based and being able to prove that what we say we're doing, we are doing. Because if we're not doing that, then potentially funding streams and money dries up and things start to go wrong. So it is quite important to be able to measure what we're doing, isn't it, in terms of the funding streams particularly. So that brings us to the end of today. A very different day in the world, which we will remember for many reasons, I'm sure. And so a big thank you to all our speakers today, both within the plenaries and breakout groups. And today's take-homes for me, community collaboration and working with our communities. With us, not to us, because working with our people, working with our communities and our population gets us a better result. Networks of people who are interested are the important link, and the energy they bring to the room and the energy they bring to the projects is really important, and harness that. And if we get anybody coming forward with any energy and enthusiasm to deliver something, let's support them and let them try. to do what they need to do. And that's, above all, I think another message coming out is let's reconnect with nature. Let's use what we've got around us in Wales in great quantities and reconnect and get the benefits of that for ourselves. Because without people that are keen and leading and bring the energy to the table on lots of these things we're trying to do, then we won't be able to do them. So make sure you look after yourselves as much as you look after others. And I think the other thing I take away from this is public services, and we in public services don't have the answer to everything. The answers lie out there in our public. They're not always lying within public services. And very often we go forward and we ask the question, don't we, of the public services, how are you going to help us with this? And I think public services sometimes need to sit down with us and say, okay, how are we going to do this together rather than one depending on another? So thank you for today. Safe journey home. Those who are coming tomorrow, I will see you tomorrow. Bit of a different day tomorrow, a bit of a different reflection, but thank you all for coming. And as I say, safe journey home. Thank you.